Yeah.
Good morning, everyone. Welcome to the day 4 of the GIAN program. So, for today's first session, I would like to invite Dr. Rakesh Pilania, Associate Professor, Department of Pediatrics, and Dr. Sanjeev Naganur, Additional Professor, Department of Cardiology, to chair the first session of the today.
The first session will be on long-term health in young adults with a history of vasculitis and normal coronary arteries. So, Ma'am.
Thank you. I appreciate Mr. Chairman and persons concerned in this session. Long-term health in young adults with a history of Kawasaki disease and normal coronary artery. The aim to know the fate of the coronary artery in patients without coronary artery lesion in the acute phase of Kawasaki disease. I will present the data from our previous studies. First, the data is diameter of coronary arteries of the late period, 19 patients who had KD, 42 patients had no CAL, and 48 patients had transient dilatation in the acute phase of KD by two-dimensional echocardiogram. In this study, transient dilatation group include regressed aneurysms within 60 years. The onset of Kawasaki disease in the respective groups are shown. The diameters at the proximal portion of the coronary arteries were measured as shown in the figures. The measurement was compared with them of control matched gender and body surface area. The area to examination of 2D was shown in the respective group. The initial from the onset of Kawasaki disease to each examination was shown. The results were shown in the right coronary artery. In the upper figure, the values between no-CAL group and control group by paired t-test. There was no significant difference in the two groups. In the low figure, the values were compared transient dilatation group and control group. There was no difference in these two groups. On the other hand, in the left main coronary arteries, although there was no significant difference between no-CAL group and control group, there was significant difference between transient dilate group and control group. The diameter in the transient group were bigger than those in the control group. Further, the results same in the left anterior descending artery. In summary, the growth of coronary artery in the no-CAL group after Kawasaki disease was normal. However, the diameters in the transient dilatation group may be bigger than normal. In the second, we evaluate the coronary artery wall in the late period intravascular ultrasound. 28 patients were studied. The median age of IVAS study was 17 years. The median mean interval from the initial coronary angiogram study to IVAS study was 14 years. All 28 patients had underwent an initial coronary angiogram less than 100 days after the onset of KD. In this study, 17 segments without aneurysm in 3 major branches at the initial coronary angiogram. There is no internal thickening in the patient. The diameter of the coronary arteries in the initial coronary angiogram had grown significantly in the late period. Here we see the relationship between the coronary artery diameter at the initial selective coronary angiogram and the degree of intermediate thickening measured by IVAS more than 10 years later in the branches. Intermediate thickness in all 70 segments were less than 0.5 millimeter. They were considered as within normal limit. In summary, there were no intermediate thickening in the late period at coronary wall without dilatation. In the third, we evaluate wall thickening in the coronary artery after Kawasaki disease by DSCT. This is the image presentation. The left figure shows small aneurysm at the right coronary artery in 2-year-old boy at 3 months after KD. The right figure shows regression of aneurysm 1 year after Kawasaki disease. This imaging in MPR, multiplanar reconstruction of the right coronary artery at the 20-year-old patient. There was no thickening at the coronary artery wall. "25 patients who had regressed or size decreasing aneurysm, and 3 patients without CAL were examined by CT more than 5 years after acute KD. The median age at DSCT was 16 years. We investigate the relationship between the coronary artery diameter at the initial selective coronary angiogram and the wall thickening. In the coronary artery less than 3 millimeter in the initial coronary angiogram, thickening was not detected. At the coronary wall without dilatation in the acute phase, there was no wall thickening in the late period. In the fourth study, we evaluate coronary flow reserve at left anterior descending artery by transthoracic echocardiography. The number of patients was 43 patients. The patients were divided into 3 groups, depending on coronary artery region. 16 patients had no CAL, and 40 patients had transient dilatation. Although 30 patients had coronary artery lesion at the right coronary artery, they had no CAL in the left anterior descending artery. CFR is respective group were compared with the 7 normal control. In BMI, blood pressure, and fasting glucose, there were no significant difference in the fourth group. In the measurement of serum lipid, there were no significant difference in the 4 groups. CFR measured during intravenous administration of adenosine triphosphate at fasting. CFR was calculated as the ratio of hyperemic to basal mean diastolic flow velocity. The result was shown. In CFR, there were no significant difference in the 4 groups. In summary, coronary flow reserve at the coronary artery without dilatation in the acute phase is normal. In the last, we must say the prognosis into adulthood for those with normal coronary arteries. We have never encountered cardiac events in patients without CARU. In the acute phase, for 30 years in our institution. Further, there is literature in the world, as long as I know. However, even if a few cardiac events happen, it may be very difficult to clarify the relation between cardiac events and acute vasculitis due to KD in such patients. The coronary artery, which have not been dilated in the acute phase of Kawasaki disease, has grown up to be almost normal. There is no thickening in all of them. Their function, which speculated from coronary flow reserve, seem to be normal. Coronary artery without dilatation in acute phase in childhood have been almost normal in young adulthood. The vasculitis alone without dilatation due to Kawasaki disease don't affect on the prognosis in those patients on now. To demonstrate the prognosis in this population, very long and mega study to know the coronary risk factor would be further needed in now. It remains unknown whether the acute vasculitis of KD reflects on atherosclerosis in adulthood or not. We assessed arterial endothelial function in patients with coronary artery lesion. Flow-mediated dilatation in the brachial artery was measured by high-resolution B-mode ultrasonography. Slide is shown. There were no statistical difference in percent FMD and percent NTG between KD patient and control. However, percent FMD in male patient who had undergone CABG was significantly lower than that in male patient. Endothelial dysfunction in the brachial artery of patient lesion caused by Kawasaki disease was not detected in this study. Systemic arterial endothelial function in the late phase of KD may be related to severity of acute KD vasculitis. FMD can be measured automatically. The slide shows short axis image. The result is reported immediately after examination. Patient characteristics is shown. There were 37 KD patients and 5 control. Comparison findings are shown. There was no difference between two groups. There was also no statistical difference in percent FMD between KD patient and control. There were also no statistical difference in percent FMD and percent NTG between KD patient and control. The third presentation, characteristics and fate of systemic artery aneurysm, caused by KD. Systemic artery aneurysm developed in approximately 2% of untreated Kawasaki disease patients and 10% of patients with giant aneurysms caused by KD. SAA refers to aneurysm developing anywhere in the arterial system other than coronary artery circulation. We retrospectively reviewed the medical record and angiogram of the 20 patients with SSA seen at National Cerebral Hospital in Japan from 1980 to 2030. First, the patient characteristics were analyzed and distribution and fate of SSA was also evaluated. Second, we analyzed the residual rate of SSA in the late period and the incidence of stenotic lesion in the 11 patients with SSA who underwent initial angiogram less than 4 months after the onset of KD. Initial angiogram had been performed from 1 to 53 months with a median of 3 months. The follow-up angiogram visualized SAA was done in 17 patients, concurrently with their selective coronary angiogram. The age at latest angiogram scanned from 2 to 26 years after acute KD. The median was 18 years after the acute episode. First, we see characteristics of patients with SAA. In the left pie graph, there are 14 males and 6 females. All had bilateral coronary aneurysm, and 19 had bilateral giant aneurysm. In the right pie graph, the onset of age of KD ranged from 1 to 20 months with a median of 6 months. The slide summarizes the result of acute KD and its treatment. The initial therapy for acute KD was started on day 5 plus minus 2 of the illness day. The mean duration of fever was 24 plus minus 12 days. The number of patients receiving acute treatment, 17 patients were seen before the 2000 prior to current advances in treatment for acute phase of KD. Late treatment is shown. Antiplatelet agents after acute phase were prescribed in all patients, and 8 patients, 40%, received warfarin with antiplatelet agents. Cardiac events occurred in 15 patients. Acute myocardial infarction and coronary artery bypass grafting occurred in 7 patients and 8 patients, respectively. 4 patients died. Next, we describe the SAA. All 20 patients had at least one pair of symmetrical aneurysms in bilateral peripheral arteries. 16 patients had multiple aneurysms with more than one pair. The distribution of SAA is shown. Brachial artery aneurysms were present in 28%. Common iliac artery and internal common iliac artery aneurysms were 20 and 21 respectively. Aortic aneurysm developed in 7 patients. We present some typical cases of SSAs. In this patient, the aneurysm in the lateral thoracic artery and brachial artery had regressed 6 years after the onset of KD. In this angiogram, changes of bilateral brachial aneurysm are shown. The diameter of the left brachial aneurysm had decreased after 18 years, while the right brachial aneurysm developed segmental stenosis with calcification. In this patient, we see regression of aneurysm in the bilateral common and internal iliac artery by the age of 13 years. In this patient, localized stenosis with calcification were found in the right common iliac artery. Both internal iliac arteries are occluded with calcification and asymptomatic. One patient who had developed a large abdominal aortic aneurysm and bilateral common iliac aneurysm, more than 30 millimeters of diameter, underwent replacement using artificial vessels at 23 months old. He has been symptom-free for 24 years post-operation. However, he has sudden death in the middle 30 in lost follow-up. The fate of SAA in the latest angiogram of the 17 patients is shown. 25 SAA had regressed and 27 SSA persist. Although 30 SSA developed stenotic lesion, there were no symptoms. The residual rate of arterial lesion in brachial, common iliac, and internal iliac arteries at 10 and 20 years after the onset of KD were 66 and 51% respectively. Residual arterial lesion included persisting aneurysm and stenotic lesion. Further, the incidence of stenotic lesion in the brachial common iliac and internal iliac arteries at 10 and 20 years after the onset of KD was 6% and 25% respectively. The acute phase diameter SSA leading to late stenotic lesion was more than 10 millimeters. In the next slide, cutoff values of the aneurysm, diameters leading to residual SAA, and calculated using ROC curve, although there was a limitation as correction for body surface area was not done. Cutoff value of the internal diameter for aneurysm that subsequently persist as arterial lesions in the brachial artery, common iliac artery, and internal iliac artery were 6.8, 9.4 millimeter, and 10.7 millimeter, respectively. Among patients with KD and SAA, the brachial and internal iliac arteries are the frequency of regression of peripheral artery aneurysm in the brachial, common iliac, and internal iliac arteries was 34% at 10 years after the onset of KD and 49% at 20 years after the onset of KD. Frequency of stenotic lesion in the brachial, common iliac, and internal iliac artery was 6% at 10 years after the onset of KD, and 25% at 20 years after the onset of KD. The acute phase diameter or SAs leading to late stenotic lesion was more than 10 millimeter. The fate map is shown in figure. In summary, among patients with KD and SAA, the brachial and internal iliac arteries are most commonly affected. Of great interest is that most of SAA were bilateral, symmetric, and multiple and were detected during first 8 months of life. The outcomes of SAA resemble those of coronary artery lesion. Some aneurysms regress and others persist, and larger aneurysms often lead to stenosis. Like coronary arteries, the late fate SSA also depends on their diameter in the acute phase. Although no symptoms were caused by stenotic lesion in our series, cases with symptoms caused by occlusion by SSA have been reported. Because the patient with SAA also had severe cardiac sequelae, their outcomes were poor. Although SAA may not always influence outcome, the existence of SAA indicates acute severe vasculitis and increases likelihood severe cardiac sequelae. Screening for SAA is possible by physical examination of the brachial artery. Brachial artery aneurysm could be detected by palpitation. The confirmed SAA non-invasive imaging modalities such as two-dimensional echocardiography, computed tomography, angiography, and magnetic response MR of examining extremities should be performed in patients with giant aneurysm. SAA occurred symmetrically and were multiple in younger infants and those with severe acute vasculitis. The fate of SAA resembles that of coronary artery aneurysm and depends on its acute phase diameter. The larger SAA can lead to stenotic lesion in the late period. Thank you for attention.
Thank you very much, Professor. Lots of learning. Excellent. So I have a couple of questions for you. Number one is, what is your advice on a Kawasaki disease child with no coronary artery involvement in the acute phase? How frequently and how long we should follow that child? Every 3 years, every 5 years? Until what age?
Yeah. In each country, there is different. In Japan, each year until 5 years, for 5 years. But USA until 1 year. But normal coronary angiogram, normal coronary artery, in now there is no follow-up, I think.
This is very tricky in children with transient dilatation of the coronaries during acute phase. When they transit from pediatric to adolescent or adult age group, then they come to the internal medicine guy or the cardiologist. And how frequently we should follow them?
About 80 years old, transfer to in adulthood.
Any angiogram should be performed like CT even in the normal coronary? Clinical follow-up is enough?
Yeah, in normal don't use, but coronary artery lesion persists and large aneurysm in regressed. In case large aneurysm regressed, we use CTA or MR 5 to 10, each 5 to 10 years.
Thank you, ma'am, for the excellent talk. So, what we have learned is that systemic artery aneurysms can be seen in 10% of children with giant aneurysms. And it's more important that mostly it has been seen in infants. And the severest systemic artery aneurysm has been seen in less than 8 months of life. So, again, to prove that infantile KD is a severest form of Kawasaki disease, and this, if there is a severe form of disease and giant aneurysms are there, the possibility of systemic artery aneurysms are high in children less than 1 year. So, if there are any questions,
in children with systemic aneurysms, they are asymptomatic. How often you will plan the next imaging?
MRA?
So how often you will follow up?
Yeah, in each 5 years.
yes,
Excellent follow-up. I want to ask is that in one of the studies you have shown that children who had transient dilatation during acute phase of Kawasaki disease, their internal diameters was significantly more than the children who had no coronary artery lesions. So is this a good thing to have a larger coronaries, or does it lead to some problems later on?
Yeah, about 4 millimeter. Yeah, and less than 4 millimeter in regressed, I not to be normal in growth.
The diameter remains larger significantly in transient dilatation.
Yeah,
Should it be
but
if there's no obstruction?
but more than 6 millimeter regressed, and I check about 15 years old. I check CT, small calcification, often small calcification detected.
Okay, so in normal CAL, the follow-up is not that long. But if there is no aneurysm but only transient dilatation,
Yeah.
then how frequently follow-up is required? Is CT required or not?
No, transient dilatation, small aneurysm regress, transient dilatation, no CT. We use no CT.
And how long do you continue with the follow-up on echo?
About 20 years, but I will check each 5 years.
yes.
Ma'am, there are 2 or 3 questions for Dr. Sanjeev as well, and ma'am, if the clinical, it is probably during the acute phase that you are asking. So during the initial presentation. During initial presentation, as of now, there are no preset guidelines, and the literature is also silent on that. So now we have just curated our data, and in the days to come, probably you will see some guidelines coming from this place. When they should be done, in which clinical setup they should be done. If this transient coronary dilatation, usually it will revert back to normal. So what probably Madam said, correct me if I'm wrong, the lesions are less than 6 mm, usually they fall in place. So as of now, there are different guidelines in different countries, and people have different understanding of this disease. So there is no consensus as of now. As far as Dr. Sanjeev, your question is concerned, from the Jane Burns group, they say if there is a coronary artery dilatation, just when this adolescent goes into his normal life, 18 years, 20 years, they just do calcium scoring or in a CT angiogram. If they are normal, they say you are free from the clutches of Kawasaki disease and have lead a normal life. Okay, so there's only 1 or 2 studies regarding this, because Kawasaki disease, if you see historically, is not more than 50 or 60 years old. The things are coming in place because those children which were diagnosed in 80s or 90s, now coming into this phase, everybody is looking into that aspect and trying to formulate the guidelines.
The proportion of systemic aneurysms are very less. So in the severe form of the KD, do you recommend sequentially doctor every 6 months to screen or after diagnosis to monitor?
Yeah. In giant aneurysm, in giant aneurysm patient, within 1 year, in 1 month, each 1 month, I follow up. Within 1 year is there is remarkably change in patient and remarkably and close follow up. But after 2 years after KD, in each 3 months after follow up.
In systemic aneurysms, when you identify, do you think is it necessary to concurrently polyarthritis nodules also to be investigated?
Yeah.
I'm just asking the immunologist.
It's difficult, and in infancy, echocardiography, I used echocardiography in extremities. We check, and if suspected CTA angiogram.
Regarding man's question of dilated coronaries, I do coronaries as well. So we see so many adult patients undergoing angiography for some other reasons or suspected atherosclerotic coronary disease. We see so many times dilatation of coronary arteries without any stenosis. So if there is no stenosis or significant stenosis and there is no slow flow, the flow, there is no obstruction but the flow will be slow. If there is no slow flow, if there is no obstruction, then they will fare as normal as otherwise normal coronary arteries will. So dilatation as such should not cause increased risk of MI, should not cause increased risk of ischemic arrhythmias, should not cause increased risk of LV dysfunction, should not cause increased risk of sudden cardiac. Isolated dilated coronary arteries for that particular body surface. So they might be having some transient dilatation, who knows? We see at least 5%, I must say, we see dilatation. Because the Indian standard for our body surface area is 4 to 4.5 millimeters the left main, 3.5 to 3.9 is the right coronary artery, LAD is around 3.4 to 3.7. But it depends on if you can index for the body surface area, some people are around this number. So even if you have dilatation, without symptoms, with good flow, does not have any
Systemic aneurysms are common in infancy. So, suppose an infant had an incomplete KD with no typical features of Kawasaki, with giant aneurysms and aortic aneurysms also, then we have a close differential of infantile Takayasu.
Differential? Yeah.
Here with the infantile
Yeah.
KD, we give the two-phase therapy.
Yeah.
Whereas in Takayasu, we give maintenance therapy also.
Yeah.
So how do you discriminate the
Yeah.
infantile Takayasu,
Yeah.
especially if there are no peripheral features of Kawasaki
Yeah.
in infants?
Yeah. In Takaya's case, is abdominal aortic aneurysm is common, and abdominal aortic check and fever, duration of fever more consistent in Takayasu. But Kawasaki disease is self-limiting, and symptom in symptom check differential diagnosis.
Maybe the duration of fever we can relay on, the other features are not.
possibly what man implies is that if there is a persistence of inflammation, chronic inflammation is there, then possibly you will think more for cardiovascular because chronicity. But again, as I have also asked, with differential to polyarteritis nodosa. So it could be a diagnostic dilemma, but more than that, the monogenic form of polyarteritis nodosa that is AD deficiency should be investigated in this age group whenever you are seeing systemic polyarteritis, arterial aneurysm. So again, it may be possible that we are dealing with some monogenic form of polyarteritis nodosa that is direct. So if there are any other questions, comments. Yeah, and we can conclude this session. Thank you, ma'am.
Thank you.
Thank you, ma'am, for the interesting session. Now for the next session on CTC anatomy and the pathologies of coronary arteries, I would like to invite Dr. Manful sir to chair the next session.
Good morning, everyone, and welcome to this fourth day of the GIAN program. And till yet, the experience has been wonderful, and probably everybody has enjoyed and might have learned the various aspects of Kawasaki disease related to the long-term follow-up. During the initiation of this program, we thought we'll try to touch the basics as well. Touch upon the coronary artery anatomy, which you may not be aware of cross-section anatomy. We thought we would have a session on this. We will discuss the coronary artery anatomy that you see on the CT. In the same guideline, we will share you through the various pathologies that you can encounter in Kawasaki disease, both as presentation and during the follow-up. And to discuss this anatomy on the various aspects that we see, we use volume rendered images. These are the technologies, or the coronary format images, axial images, how the arteries are seen in various forms. So Dr. Arun is going to discuss this. Dr. Arun is a PJ alumnus and is a DM in Cardiovascular Radiology from Orine Institute, and currently works as Associate Professor in our department. Dr. Arun, please.
Good morning, everyone. So I will be discussing about the anatomy and pathologies of coronary arteries in Kawasaki disease. So, as we know, the heart is a pyramidal shaped structure of the pericardium, and with a good amount of epicardial fat, where the coronaries are wrapped around and course predominantly epicardial with some variations. And as it is, there is off-axis rotation of the heart, so it is not in the proper body plane, and we require imaging in planes as you see on echo. So on CT, this is very easy to make, and we can the same morphology, same picture on the short axis images and 2 or 4 chamber images we can see. We can see the coronary course as mirrored to echocardiographic practice and as well as on the volume rendered images. Moreover, we should see for the ostial pathology or some branch abnormalities, because these vessels are very small and they should not be missed. So it demands a very high quality acquisition of the CT. We have to see all the existing phases which we get on CT, because there may be heart rate variability. We can see there is degradation of the images, and in some phases, if we have acquired in adaptive phases, we can see images on some good quality phase, and that should be interpreted well. And the portion which is in the artifactual range should be clearly mentioned, so as we should not miss any lesion along that plane. So we use various images as far as highlighted. First, it is the most important image for the radiologist is the axial image, and this is the normal CT acquisition image. We see pathology on this and then highlight it on the other images which shows the abnormality quite glaring. So for anatomy delineation, we can use these projections very nicely, as well as curved reformation, which can show the whole length of the coronary involvement along in one plane in one image for all the coronaries. So this, to highlight the anatomy, I will be using the adult coronary images to show exact the anatomy as well as their origin and course, which we see on the pediatric population. And these small branches may not be seen very well in case of kids, but the larger arteries are very nicely seen. So they arise from their respective aortic sinuses. The right coronary from the right sinus, which is anteriorly placed, and left coronary from the left sinus, which is posterior. And they course epicardially. We can see this aorta and the coronary, which is both the two coronaries, they are arising. This is the RCA and this is the left coronary, which is bifurcating into LAD and LCX. In one image, we can see full coronary tree on CT, some form of reformation. So, coming on to the left coronary, how it arises, the origin I have discussed. It is from the left sinus, and then after a variable length, which may be 5 to 10 millimeter, it then bifurcates into left anterior descending coronary and left circumflex artery. There may be variations in the bifurcation pattern. It may be trifurcation in up to 15 to 30% of the cases, which then may give rise to the corresponding branch, which can be ramus intermedius, which can supply to either the diagonal or the obtuse marginal territory. So then LAD courses epicardially with some portion of bridging in some cases, and it give rise to the diagonal branches and the septal branches. So generally the diagonal branches, they arise laterally and supply the anterior left ventricle, and the septal branches are medially to supply the septum. Septum branches are septal blush, they are very small branches, and generally we see for the bigger, main the LAD and the diagonal branches for any abnormality in Kawasaki disease. So then left circumflex, it courses in the left atrioventricular groove. This is the left atrium, this is the left ventricle. So the characteristic course along the groove gives rise to the name of left circumflex. This is the left circumflex. It is clearly seen, and then continuing as smaller last OM branch, and this is the biggest OM branch. In this case, we can see this is the smaller O1. These branches, they arise and they are numbered sequentially, like OM1 is smaller, OM2 is larger, and sometimes if there is larger OM, then the distal circumflex is smaller. It may give rise to the posterior descending artery or the posterolateral branches if there is left dominant circulation. Then on the right coronary, again the origin I have already told, from the anteriorly, and then it branches. The branches are, the first branch is the conal branch, which is towards the conus. So it will follow the anterior course and supply the RVOT. In some cases, it has a direct origin from the aorta. Then it is sometimes referred to as third coronary artery, but majority of 50% of the cases, it is from the 50 to 60, it is from the RCA only. but we have to see if there is any abnormality when it is directly arising from the aorta. So then it is acinodal branch. It is just for the anatomy delineation. This branch may not be seen, and these branches are so small in pediatric population, they may not be very well visualized on CT. And this course is identified that it is the coronal branch is going anteriorly and it is going posteriorly to the SVC inflow region. Then the easily identifiable branches are the acute marginal branches, which are on the acute margin of the heart, and they are known as acute marginal branches before distal RCA bifurcation into posterior descending and posterior circumflex arteries. So we can see at the crux of the heart, it then bifurcates. So this is going to the posterior interventricular septal region, like this one. It is the PDA, and which is to the posterior and inferior left ventricular lateral wall, posterior wall, it is the posterolateral ventricular branch in case of right dominant system. And the coronary, only coronary artery tree, we can see whole length of the RCA and LAD in one plane. So to better delineate, we can see the whole course of this is the origin of the RCA, right atrium, right ventricle, right AV groove. So we have to see in the groove, if on the right side it is RCA, on the left side it is left circumflex, and anterior interventricular sulcus, it is the LAD. So we have to identify it like that. We have to see for the atria and the ventricle and the corresponding grooves. So two arteries which are in the grooves is right, on the right side, right groove, it is RCA, left groove, it is LCX, and which is not in the groove in the center, it is LAD. So the dominance is, majority of the cases it is right dominance with small subset in the left dominance. So the importance is, if there is small length RCA, it is generally very small if there is left dominant circulation, and then the larger branches, the PDA is supplied by the left circumflex. So the nomenclature of the coronaries is also based on this principle, that which territory it supplies and which branches it gives. So particularly in kids, we can see the anomalous origin of the coronaries. So if there is anomalous origin, like in this case, this is left coronary and this is the right coronary from the same sinus, and this is the high origin of the right coronary. So this anomalous origin or anomalous proximal course still doesn't change the name of the coronary. If it courses in the right groove and supply the right side structure with the acute marginal branches, it is still be right coronary artery. And similarly, if we have anomalous left coronary, sometime we have anomalous left circumflex from the RCA or right coronary sinus, but it will course again in the same groove. If it is not in the groove, then it is atresia of that particular artery. So the nomenclature is, it does not depend upon its origin or proximal course. It can be anomalous, but for normal, it has to be its supply. So when on CT, whenever we review the images, we have to give particular attention for the branching points of the larger branching points, and to see for associated abnormality. Like with the aneurysm, you need to see for any stenosis as well, and you have to set or change the kernel reconstruction to avoid overestimation due to high density adjacent structures. So all lesion characteristics should be noted, like the length, eccentricity, ostial involvement, any ulceration, irregularity, calcification, vessel wall remodeling in the chronic phase, occlusion or aneurysm formation, and its dimensions and its extent, whether it is involving the branching point or whether it is involving one coronary, proximal coronary or distal coronary involvement. So coming on to the abnormalities or pathologies which we encounter in Kawasaki disease, it can be the most common in following acute phase or in subacute phase, it is the aneurysm formation. And the aneurysmal dilatation, it could be fusiform, as we can see, fusiform, where the length of the involvement or the length of the aneurysm is more than its transverse diameter. However, it can be both combined. It can be fusiform as well as saccular, also saccular when it is the transverse diameter which is more than the fusiform, than the length of the abnormality. So, as this has been shown by Sir previously also, there may be one coronary involvement like RCA in previous case, or there may be both the coronary involvement like RCA and LED in these cases, and it is the fusiform dilatation involving the proximal, mid and the distal segment. And the measurement of this, like the giant aneurysm more than 8 millimeter, particularly in children. So, or it may be the involvement of the distal, proximal as well as distal arteries, and the remodeling following this resolution of the acute subacute phase to see for the aneurysm resolution or its changes in the wall thickening, calcification and occlusion. So, CT is particularly highlighted being important for delineation of the LCX abnormalities, which may not be properly picked on echo, and we can see whole length of involvement as well as its morphology and its location, eccentricity and all features. So then subsequently we may see the changes on the wall as well as formation of calcification. We can quantify the calcium score and with it or its progression, or if it is same during the follow-up. So these aneurysm may show peripheral thrombus. There may be thromboembolic complications, or it may calcify peripherally with central occlusion. Then we have to see for the effects of this thrombus. So we have to also pay attention to the short axis images, which I already have told earlier, to see for the effects. If there is chronic ischemia, there will be wall thinning along the particular territory. If this is the aneurysm in the thrombosed aneurysm in RC, and this is the thinning along the inferolateral inferior wall in the mid cavity region. So to conclude, there is, with the advent of this technology, there is considerable change in coronary and cardiac imaging, and these advancements have enabled detailed evaluation of the anatomy and pathology of coronaries, and the knowledge of anatomy is important for accurate interpretation of these imaging findings and to avoid missing any abnormality. Thank you.
Thank you for taking for detailed evaluation of the coronary artery and cross-section imaging. Any comments or any questions? Yes.
How will we differentiate the saccular aneurysms from pseudoaneurysms in the cities?
No, on the basis of CT, it is not possible distinctly, because it is a pathological condition. Pathology which that there is all the walls are there or not, but there is some hint that there is surrounding hematoma. Only then it will be differentiated from aneurysm to pseudoaneurysm. Otherwise, they are just named interchangeably. Not 100%, it is not clear cut for aneurysm and pseudoaneurysm distinction on CT.
Usually pseudoaneurysms is a smaller neck. Usually these are the small features, but in Kawasaki these pseudoaneurysms are not being reported. So on that context, I will tell you in 3 words coronary artery anatomy. Talk of origin, we talk of course, and we talk of termination, as Dr. is highlighted. It may origin from anywhere, but usually they have a predictable course. If artery is rising from the left sinus, it has to go to the right side. It's an anomalous origin, maybe an anomalous course, but ultimately is going to the right direction. So this is the predictability, and most of the coronary arteries are epicardial. It doesn't go into the myocardium until unless they supply that area. these things are important. And as always highlighted, right side on the AV groove is the right side, on the left is the LCX, it goes anteriorly, and in the center is the LV. So I think then morphology of the aneurysm, scapular versus fusiform, as you follow them and we can have stenotropic lesions, we can have calcifications. I think if there are none question, thank you Dr. Alan
Thank
for
you, sir.
your wonderful presentation, and thanks for coming.
Thank you, sir.
We will move on to the next.
So now we will all take a short break for the tea. हाँ, उसको बताते हैं।
screen coming.
She died for you. Maybe another 1 hour. She will call you very soon.
Thank you. Oh, ശരി. നാളെ ഉണ്ട്
So, welcome all back from the tea break. So, for the next session, I would like to invite Professor Sujit Singh, Head of the Department of Pediatrics, to chair the next session after the tea break.
So, Dr. Mansoor will take up this talk on the current status of CTCA in Kawasaki disease.
Thank you, sir. As we have discussed, there is now there's a consensus that there is a scope and there is a need of CT coronary angiography in Kawasaki disease, and with the 2024 AHA guidelines, that has given us some more strength that probably the journey that we have been continuing for the last 1 decade is probably right. So in this context, we'll see what is the current status of CT coronary angiogram. What we are going to discuss in next 20-25 minutes is what is CT coronary angiogram, why it is required, and yesterday we had seen why it should be done, when it should be done, and how it should be done. So in this talk we will see some literature review, and we'll see the work that has come from this institute, and we'll explore with some examples. So there is, as we all know, this is coronary abnormalities are the hallmark of Kawasaki disease, which in acute form can be in the form of aneurysm, dilatations, and on follow-up there can be stenosis, steno-occlusive lesion, calcifications coming up. And thanks to IVIG and other immunomodulation drugs, that has decreased the incidence of coronary artery abnormalities to less than 5%. Having said so, if the abnormalities develop, then they need close monitoring. So as of now, there is no unanimity, and this is different in the different parts of the world. To begin with, it was catheter angiogram, then shifted to echocardiogram. Now with the evolving technologies like CT and MR, they are getting integrated, especially during the follow-up. And the guidelines are, as of now, are somewhat silent on its use in the acute phase, and we are trying to fill in that gap. So these are the imaging modalities that we have been discussing last 4 days. Echocardiogram is a standard of care, catheter angiogram is a gold standard, and was used to be the investigation during follow-up. But thanks to CT and MR, that has given us new hopes, and they are emerging and the new modalities. So once we talk of any modality, we need to see whether they are feasible, what is the technology. So I always say when you consider anything, you need 2 things. You need equipment and you need expertise. So until you may have expertise but you don't have equipment, then you cannot do it. And if at all there is a technique, whether it is acceptable in a particular age group, so these are things that we need to consider. So as far as CT coronary angiogram evolution is concerned, it was only possible after the advent of multi-slice CT with 64 detectors. And that was the remarkable year. And when it was 64 MD-CT, it was restricted only the adult coronary arteries, but the radiation was in the tune of 6 to 10 millisieverts. But its integration into the pediatrics, as when we had discussed with Professor Sujit Singh, he had happened to attend the IKDS in Southeast Asia, and there are some people, he told me that there are some people that were discussing the role of CTCA, but they thought it will never come to pediatrics because of high radiation and the inherent high heart rates. But thanks, with the time, things evolved, and the CTCA became reality in the pediatric domain as well. So let's see, when we talk of new, it has to be seen in the context of the prevalent or the standard of care imaging modalities, whether it's echo. Rakesh had discussed very explicitly. Echo is the standard of care, no doubt about that. It has to be, and it should be, and it will be. But we must understand that the coronary artery, though prevalent in the proximal arteries, it is not that they cannot occur in the distal segments, or they can occur, they doesn't involve branches. And we must understand this is an operator dependent. Angiogram, we have been discussing, we cannot subject our children, especially during follow-up, the catheter angiograms. Every day, 3 years, 5 years, we cannot subject these patients for catheter angiograms. MRCA, we have discussed long acquisition times, and it is restricted. MR is a very specific examination, irrespective of the part that you image, whether it's brain, whether it's pancreas. It is not something like MR abdomen. It has to be very specific. So it takes long time. In CTCA, in this context, seemed very attractive because of its short acquisition time. Excellent isotropic imaging with brilliant temporal and spatial resolution, and so with these conditions, there were whispers that whether it's scope, whether it's feasible, the radiation was always a concern, and the strength. These were the things then how we began with. But definitely, you see, when we had multi-detector CT from 64 to 320, C60, thousands detector CT, and for that matter, 2 tubes orthogonally placed dual source CTs had largely addressed these questions, and that's how this technology came into the pediatric coronary imaging in Kawasaki disease. But you see how the coronary artery disease can be is different from the adulthood. Adults' coronary heart rate is usually less than 80, but in children have inherently high heart rates. So you cover that innately high heart rate, your scanner has to be very, very fast. And if you scan but your image quality is not proper, then it's a futile investigation. For that, you need high spatial resolution. Means the image has to be very, very clear. And more importantly, when you talk of these things, if it is not radiation optimized, probably it will never come into the pediatric in the practice of pediatrics. So everything has to be met. So thankfully, these things are largely addressed now. So when these things came into picture, the CTCA slowly started moving its baby steps towards its role in Kawasaki disease. So initially, if you see the literature before 2013, it was limited only to the case reports. And the concern was the radiation and the image quality. But when the 128 first generation scanner came, probably in 2010, there was first series that came from China and published in 2010. And what this concluded is it was only on 16 patients, and they told it can detect the middle and the distal segments, and has good correlation with the echocardiogram. And they concluded that it was accurate, non-invasive, and maybe a valuable technique for detecting as well as on follow-up of the coronary artery lesion of Kawasaki disease. Since then, there are multiple publications that came up, and this publication was in the British Journal of Radiology, and it unambiguously said that there's an agreement with CTCA and the transthoracic with a good correlation, and same thing we are trying to do in our institute as well, and it has an excellent image quality with low radiation exposure. So during this time, we had our scanner in 2012, second generation dual source, and we also started our program. I don't know how it started, how the thoughts came, that I leave to, I have no answers for that. And in 2015, then again, we had a comparison, because when you start new, everybody is going to ask, does it meet the same criteria? Does the measurements mean the same? Does your imaging findings are the same with the established modalities? That was catheter angiogram, and the measurements were showing good correlation, you see. And that's how, things starts accepting into the...
Studies by Dr. Suda.
Yes, ma'am, Suda study, yes. Sorry, ma'am, I couldn't, I didn't, pay that attention. So this is a study from Madam Group that the CT angio and the catheter angiograms are in agreement as far as finding as well as measurements are concerned. So, this is how, madam, this group, told you CTC is better than coronary artery angiograms in detecting thrombus. If somebody asks me what is catheter angiogram, I will say it's the imaging of an contrast fill lumen. It will not tell beyond lumen. So, if you want to see the mural abnormality, you need to have cross-sectional imaging. And it can detect wall thickening and calcification that Arun has also showed, and we will see in the next few slides. And they have made an remarkable comment that CTCA using dual source CT is non-invasive, accurate and safe technique for measurements of coronary artery abnormalities immediately after acute KD. That's why we have seen many questions arising in this forum that when CTA should be done. Now the consensus is building up. I think in the days to come things are bound to change. Then there was another publication that was Insights of Imaging, and that also, reviewed literature on the role of CTCA and KD. And they, at this time, they had advocated the use of low dose CT or with the invasive catheter angiogram. And you see how the things change when everybody is in consensus, and consensus come when it has something to offer. Then in 2013, you see there is another paper that came in Journal of JCCT. I think this is again from China. They said ki coronary artery abnormalities. Singapore? Okay. So they say technological advancements of coronary CTCA has led to shorter scanning times, low radiation, improved image quality, and they were pretty sure that it can help in detecting the myointimal thickening versus complications, stenosis, occlusion, thrombosis, and they slightly touched upon the coronary artery abnormality detection in the acute phase. And since we started our work, we simultaneously started our publications. First publication came in 2018. At that time, we did know what we was doing, and we were struggling to write our manuscripts. And first publication came in Current Problems in Diagnostic Radiology, followed by I had an opportunity to write an article with Madam Suda that was on the International Journal of Rheumatic Disease. Then we had a review article in Global Cardiology Science, and recently we had articles in Lancet, Rheumatology Oxford. We have few images on Journal of JCR. Recently we have been publishing in World Journal of Clinical Pediatrics. Recently we got an invite from the Archives of Childhood Diseases, and this article is in press. So this is what this has happened and what we have been doing as a team here. If you have to go to the CTCA, let's go into the subject proper, what is its strength and what is the evidence like. So everybody probably are in agreement that Kawasaki disease can involve any segment, any branch of the coronary arteries, and if you have to talk of echo, which is a standard of care, is limited for diagnosing middle and distal coronary involvement, and CTCA gives the information along the entire length. LCX, which maybe is difficult to evaluate because of its course and anatomy on echo, is very well seen on CTCA. Diametral correlation we have already seen with the thoracic echocardiography as well as catheter angiogram, so there is no ambiguity about it, and it tells about the aneurysm morphology, extension, complications, and no doubt it is the investigation of choice for follow-up. So these were the first scan that we acquired in the day of 28th November 2013. So this slide I always will show in any of my presentation. So this was the first presentation. I was very anxious. Probably I may not have slept the day before because this was the first case. And when the case was acquired, I was slightly happy that at least we can get good images. So this time the imaging was retrograde. We never tried adaptive because we never wanted the examination to get, and I was not confident even. So when this scan was done, first question that was asked, radiation कितना आएगा? Sir, radiation 2.2, no, it's ज़्यादा आएगा. It's more. So I think how to reduce it, I had no answers. But slowly, first 30 cases, I requested, sir, let's do it. In the time to come, we'll change to it. And then finally, we started to adaptive ECG gating, and since then, we didn't look back, and the radiation has already been in acceptable levels. So let's see with some case examples how CTCA has been helping our clinical consultants as a problem solver. Dr. Sandesh is here, probably we saw this first case. So, if you see in this case, what you see is this is LMCA, this is LCX, LAD, LCX, and this is RCA. Okay. So what we saw, you see here is, if you have to go by the Z scores, the LMCA was diagnosed as dilated. If it is a dilated, you have to augment your treatment therapy. Once the child stabilized, we did a CT angiogram, and what we found was this was single coronary artery. Remember, what Arun has showed is there are two coronary arteries to start with, right from right coronary, left from left coronary. If all the circulation has come from a single artery, by virtue of nature, it has to be big. So if this is a constitutional large artery rather than a pathological large artery, if you know this, you discontinue your therapy. Parents and patients, you can see smiling faces, and it is so revealing. So this is a problem solving tool. Another thing that you see is this dilated RCA. Palvi is here. I don't know Palvi is here. No. So what you see over here in this image is a dilated RCA. Okay. Then when we did in CT coronary angiogram, what you find is an L-kappa. This is left main arising from the main pulmonary artery. When this will occur, there will be a shunting between the low pressure and the high pressure beds, and the RCA has to dilate. And when the RCA was dilated, we know it was not pathological. Not pathological for Kawasaki disease, and this patient was having LV dysfunction. And this patient was discontinued with therapy and was operated in time. I think Rakesh is here, and he will tell you the story about that. And he has recovered very well and with improvement in the LV functions. So with this, we thought once you start doing it, then your journey becomes remarkable. We started seeing the distal coronary arteries, and these were our eye openers. And we curated our data on 176 children about the role of CTCA in diagnosing distal aneurysm, and this was published in Rheumatology. And yesterday in the dinner, Dr. Sandesh was telling me, sir, manuscript ke citations bahut ho gaye hain. I mean, yes, there are, this is one of the most cited our publication about the role of CTCA as far as distal aneurysms are concerned. So we'll see some examples with this. This is not a rocket science that this dilatation will not be seen on echocardiogram. But what about the distal extension? Distal extension can only come through, the CTCA. You can see this aneurysm, but you cannot see the branch vessel involvement. Measurements are pristine. Yesterday I was discussing with the CMC Vellore team, sir, what about, Dr. Murugan is going to present about the correlation between the CTC and echo. The measurements on CTC, I think they are the way forward. And because they are, variably inter or intra-observer variability, and days are not far when we have automated detection software to take care of that, some variability that may exist. You can have discontinuous aneurysms. You may detect proximal, but middle and distal you cannot see. You cannot see the basal wall in movement. This is how the CTCA comes in the picture. And if you talk to Madam Suda's group, and these are the patient who needs follow-up, close follow-up on CTCA rather than echo. You can have distal aneurysms. You can see this distal aneurysm, branch point aneurysm. You can have dumbbell-belt aneurysm. You can see this one, but this may not be difficult to detect. And this was the patient that Dr. Rakesh was discussing yesterday, isolated RC aneurysm. There was no aneurysm or abnormality in any of the proximal coronary arteries. Then this patient we discussed yesterday was have a relentless course. You see pleuropericardial effusion, pericardial window has to be created. All the arteries was dilated. You see the pan-coronary involvement. And this child we just did an MR on this, doing very well. You can have, aneurysm in the distal branches. This is an OM1 branch of the obtuse margin. Like you see a bunch of Graves appearance. very nicely seen on the other curved reformated images as well. So these aneurysm by no imagination can be seen by echocardiogram. Then you can see this complex aneurysm arising at the branching point, going into the proximal LAD, going into the diagonal wall, and involving the ramus intermedius. And you can see there is no hypodense filling defects, even that can tell you that there is no thrombus. Then you can have the complex aneurysm. You see this, this we lost this child very recently. So this child had, developed a large, I will show you that follow-up image, then we'll discuss at that time. The LCX, you can see the distal aneurysms. Complications you can see in the form of hypodense filling defect, in the form of this thrombi here. It is a small volume thrombus, you can never detect on echocardiogram. This is a small filling defect over here. And you can see, images. Sureshji, can we have this lights? You can see this, can you see this filling defect over here? Same you're seeing on this image. Then you can see complications in the form that, this is a calcified aneurysm, and calcification is a killer of ultrasound. Air and calcification. You will not see anything if there is a calcium and the air. So these aneurysms you cannot never see on, whether it's proximal. You will not be able to see on echocardiogram. So either you need a catheter angiogram or you an MRC or CTCA. Echo is out. So you see this example that we discussed yesterday. So this was an acute presentation. This is an LAD which is thrombosed, and you can see subcollaterals. There is a large aneurysm in the RC as well, and you can see 1/3 of the ventricle which is aneurysmal now at the apex. And you see about the status of this RCA, large giant aneurysms. You see, I've never seen this big aneurysms. This was a delayed diagnosis. Then you can see morphology that we have discussed in the previous case, how the branch vessels can be involved. You see the morphology of this aneurysm, see this large secular aneurysms. This is fusiform aneurysm. Why we are interested in this? Because these fusiform aneurysms are, more prone for complications because of altered hemodynamics. And these are the reconstruction images that you can see about the contents of this aneurysm. Then an important thing that is coming, how to now, we are at this stage, now we have started getting the follow-ups also. 2013 to 2015, 12 years our journey, now we have started, getting the follow-ups. So I will show you this example. This patient had aneurysms in the proximal RCA, whole of the RCA was aneurysmal. This was a complex aneurysm. Then after 3 years of follow-up, you see only the aneurysm are restricted to the proximal RCA. And you can see the large LAD aneurysm has remodeled, and you see small aneurysm which is showing some calcification. No stenosis whatsoever. This is a patient on follow-up that we show, and on this follow-up what you saw is this. You see there's a tight stenosis at the proximal LAD, another tight stenosis at the mid LAD. Ma'am, you were asking is sensitivity and specificity. What can be more specific than this? And these are the patient, once you know this, yesterday we had seen lecture of Dr. Suda ma'am when to consider myocardial perfusion imaging, whether it be in MR or myocardial perfusion imaging. So these are the patients who require myocardial perfusion imaging. If there are defects, then patient has to be intervened either in the form of whatever the treatment that we can offer. So this child was an athlete and mountaineer. Used to love mountaineering, and suddenly he collapsed when he was climbing. So we have trying to integrate. This is the example that I showed previously. At now after 3 years of follow-up, what you see, large calcifications has come up. These aneurysm has remodeled, you see. But there is, there may be some suggestion of some stenosis, especially in this LAD segment. So we are planning for myocardial perfusion imaging on this kit. You see these images, heavily calcified. Calcium score, you see it's, Tapas sir, you were asking me the calcium score. The calcium score is 551. The calcium score is more than 80 years in this 10 years. You see how severe is the calcium burden. Then we always see, till yet we have seen all the cases which were diagnosed as KD in the childhood. But as an adult cardiologist, sometimes you see abnormal coronary arteries, which you cannot define that they are atherosclerotic. So before this, the first data that came was from Professor Jane Burns group that was on catheter based. So in 2015, we with our adult cardiologist, curated or analyzed 11,000 CAT data, and we found 4-5 patients which was of probable missed KD origin in their childhood. So with that same data, we started seeing our CT angio data prospectively. And you see there are some abnormalities which tell that they were probably missed KD, because as madam was telling in the morning as well, KD is a self-limiting disease. At that time they might have KD, they might have fever, they might have taken some antibiotics, things might have resolved, but they continue to keep symptomatic. And when they are symptomatic, they will come to us for CT angiogram. And what you see is over here is, you see these arteries are dilated. This proximal, you see the proximal RC is dilated, distal RC is dilated, the proximal LAD is dilated. This dilatation, this skip dilatations, you will never see in atherosclerosis. So probably this is missed KD. So we called their parents, asked them very specifically, did this child has this type of disease? Out of 5, 3 was categoric, no, they had this kind of symptoms. So we attributed this probably due to Kawasaki disease, and sir had suggested to keep them on aspirin. So this manuscript is already accepted in press. So we have 5 cases like that. So this again a missed KD of childhood. This is aneurysm. This is calcified aneurysm. Calcification only restricted to the aneurysmal segment. There is no differential diagnosis. This cannot be atherosclerosis other than the Kawasaki disease. Now with this we have discussed. Now the $1 million question comes of the radiation. So we curated our data for the radiation as well. The radiation across the age groups we calculated, and the radiation was well within the limit of 1 millisieverts, especially in the age less than 1 year. As the child will grow, our more is the body mass, more energy we have to give. So the radiation may slightly increase more than with 1 mole sieverts. So this is a journey, and this is the experience of the leaders across the globe, and we have discussed our experience as well as of CTCA, and we are quite happy, contented that this modality has now started seeing the light of the day and helping our community. Now with this, should we stop here? No, lot many things are there to offer. As of now, we are only seeing the morphological images. Can we have some hemodynamic information on these aneurysms that can predict about whether they will increase, whether they will decrease, whether they will have calcifications, whether they can have a thrombi? So then the time has come from morphological images to functional assessment. And the functional assessments can be on the flow dynamics. And with this, when we talk of these morphological images, we talk of hemodynamic changes, then everything will be individualized then, and that's the time that has come. Every patient is different, every lesion is different. So basically we are also working on this subject, and hopefully if everything falls into place, we will have that assessment as well. And these are the things that you can reconstruct: wall shear stress, hemodynamic stresses, pressures on the things, on the aneurysms, on the walls, for prediction of the future cardiovascular events. So with this, if you see, CTCA non-invasive investigation shows CA along the entire course, along their long branches. If you have to compare with catheter angiogram, it detects the mural abnormalities as well. It delineates the temporal change of coronary artery abnormalities, which may be in the form of resolution, stenosis, thrombi, mural calcification, remodeling, and more importantly, as a pediatric cohort, the radiation exposure is acceptable. And more importantly, it has an excellent correlation with echo and angiography, which is now beyond doubt and well established in literature. So with this was our statement 5 years back, potential to become a standard of care. If you see the 2024 guidelines, they have integrated the role of CTCA, but they are using the word can be considered. And I think in the next guideline, this can be will be changed to should be considered. And in my personal opinion, it should be considered. As of now, it is restricted to follow-up, and its role at initial presentations remains silent, both in the guidelines. Let's see how can our experience can help the community. So with this, I think I should finish, and questions, if any, please welcome.
Thank you, Dr. Mahfood. So this talk is now open for comments.
Yes, ma'am.
We usually say like if there is a fall in a child, especially infant, and neurosurgeons are always after CT scan. But literature it has mentioned that if you do CT scan of a growing brain, especially in first year of life, chances of developing malignancy is 1 in 1500, which is very high. So what if you have to convince the parents, as we normally say that one CT is equal to 150 X-rays. So what is the ratio now for the latest CT machines, and just to convince, because radiation everybody is very aware of.
Yes, ma'am, we have been doing in infants, the radiation exposure will typically be varying from 0.2 to 1 millisieverts, which is just equivalent to 5 to 10 X-rays. Same is with head. You know, ma'am, the problem lies, what Professor G. Singh was, I'm fortunate to work, to having these working with him. You see, most of the radiology centers, I may be, if I make this comment in our forum, it may draw a lot of criticism, but this is the fact. Most of the scans are done by technologists and they don't have protocols in place. What's the fun at doing the pediatric brain at 100 kV? Not at all. You can do it 80 kV, that's fine. Now, CTs nowadays is just like an X-ray of brain. Only you can see fractures, you can see some lesion or maybe some bleed, otherwise MR is a way forward. So we need to, the time has come to go, till the time we have to leave our comfort zones. You have to change. We have to change. Where you have to change.
CTs are taken very casually, and both by clinicians as well as by the radiology colleagues. So there are ways and means of decreasing the radiation, provided you put in that effort. But that effort is generally not there. And as Dr. Mansoor said, at most places, even in teaching hospitals, the CTs are done by the technicians, and the radiologist only interprets them. So that is the issue.
And to my understanding, this is my conviction actually. Until unless we have things protocolized in place, Dr. Rakesh made a very good statement yesterday. People may come, people may go, things may change, but protocols will always stay. We always tell, Gopika is sitting here, I tell them, we have made reporting protocols. I say this protocol is just an umbrella. But your reporting starts with your name. You check the name, you change the date, you see the PG numbers, scan numbers, protocol. She's sitting over there, in the morning she will tell me, sir, ye form aaya hai, what is the protocol? So I type her and tell the protocol. In CT scans, every scan is protocolized.
But as you highlighted, ma'am, I think all residents, what Dr. Puneet has said, we need to remember that each CT that we do, we increase the risk of malignancy by some extent. And CTs are taken very, very casually. In our institute, for instance, a CT can be ordered by the most junior resident. While for MRI, it has to be the consultant. I think it should be the reverse. MRI will not harm, while a CT can definitely harm.
I just want to comment that this is for residents. I have been in practice for 30 years and I have never been screamed shouted by any of the tenants. And I am a pediatric intensivist where all the deaths occur. So I think we doctors are responsible if we are not given proper respect. So we being a referral hospital, we get lots of patients. This is not to KD, but in general with pain abdomen. And they have like 3 CTs, 10 ultrasounds. Nobody has asked the child where is the site of the pain. So creates abdominal pain. 7 years old and he would say, ma'am, yahan pe. This is epigastric. And I tell him, bete, yahan pe sharp pain hone ki garam lagta hai. Ma'am, bahut garam lagta hai. Because he's been given brufen, mefenamic acid, and he's got a simple APD. But uske liye CT, sare normal sir. CT is taken so casually, and particularly for females. We females are carrying our baby right from the day of our birth. Everybody knows that. That's why we are more attached to our children. Because I'm carrying my granddaughter also. So that is why exposing females with pain abdomen to CT, what are we leading to? Future mutations and malignancy would be there. So if we are casual, then we'll get the casual behavior from the people. So I request to all, because I see lots of youngsters, do not say that patients bigger rahe. Just like we say, bachche nahi bigger rahe, parents bigger rahe, doctors bigger rahe. That's why patients are reacting the way they are. So be good, ethical persons and nothing would go wrong.
Satish.
Sir, actually, in our institute, the children see the thorax, abdomen, everything is now, we have modified. The ability is very low, and even the talent is very low. So when you discuss with the pediatric radiology and the radiology team, and the CT abdomen for the adult and the children is entirely different. There is a low radiation component is there for all the sections like thorax, abdomen, brain.
Yes.
Very good.
Very nice to hear, ma'am. Another thing that we as this I'm talking of a society perspective that comes about sustainability. It doesn't mean you may have a lot of money, you can do anything. You will bath with 1,000 liters of water. No, it is a criminal waste of money. Everything has to be justified. Everything you have to see in the term. We have to, the way society has been going कि मेरे पास इतना पैसा है मैं कुछ भी कर लूँगा. No, this is those people. This mentality we need to curb it. Yes, please.
Casually done CT test and abdomen. Sometimes this is a reasonably common investigation. Suppose a child comes with fever, without thinking we order a CT test and abdomen, and if it is done casually, the radiation exposure can easily be to the tune of 10 millisieverts.
Yes. In adults, no surprise.
And if you top that up with the nuclear scan, the PET CT, that will be another 10 millisieverts. So these are two tests which you should think 100 times before ordering the child. A PET CT and a CT test abdomen combined. You hardly ever need it.
Sir, for an infant with giant aneurysm, how frequently would you follow up with a CT?
These are the guidelines, but for your question's sake, what we are trying here is any child of, we have our own criteria. At initial presentation, we will have CTCA when the child stabilizes. Thereafter, it's from 2 to 5 years. Supreet had presented very nicely yesterday, if you had missed it. Any other? Okay. Thank you, sir.
Thank you, sir, for sharing the information on CTCA with us. Now for the next session, for the oral presentations by the delegates, I would like to invite Professor Tapas Sabui and Professor Saji Phillips to chair the session. And for the first presentation, I would like to invite Dr. Akash Rastogi for his presentation.
Good morning, everyone. So, good morning, everyone. Myself, Dr. Akash Rastogi. I'm a junior resident at Department of Pediatrics, Dr. RPGMC Kangra. Today I have with me a comparative study comparing the varying presentation of Kawasaki disease in patients with coronary artery aneurysms versus patients not having coronary artery aneurysms. Talking a little about Kawasaki disease, as we have all heard for the past few days, Kawasaki disease is an acute self-limiting vasculitis affecting children of all ages. It is a leading cause of acquired heart disease in pediatric populations, and development of coronary artery aneurysm, which is a major complication of KD, has devastating long-term consequences. CA is known to occur in about 25% of the untreated patients of Kawasaki's disease. Resolved patients with CA may suffer from myocardial ischemia of subclinical proportions. Coming to the study objectives, I compared the clinico-demographic and lab profiles of KD patients who developed coronary artery aneurysms versus patients who did not develop coronary artery aneurysms. Methods, the study setting was the hospital Dr. RPGMC Kangra. Data shows we reviewed the case records of the patients over a span of time, and we mainly compared the clinical features and lab parameters of our two groups. Coming on to the demographics, as we see here, the total number of patients with CA were around 11, and the total number of patients enrolled for the study were 53. The 42 patients of KD did not develop CA. The male to female ratio was comparable, as we can see, 2.6:1 and 2.8:1. The mean age at diagnosis in months was also comparable at 45 for the first group and 43 for the second group. But the difference comes when most of the patients with CA at time of presentation were diagnosed as cases of incomplete KD as compared to patients who did not develop CA, accounting for 73% in first group and 54% in the second group. Coming on to the clinical features, the starting thing here is that the fever duration is almost comparable, but the clinical signs were less evident in the patients with CAA as compared to patients with not developing CAA. Mainly the difference lies in the lymphadenopathy, comparing at 54% for the CAA group and 74% for the non-CAA group, and desquamation, which lies at 64% for the non-CAA group and 45% for the CAA group. But overall, we can see that the clinical signs were less evident in the patients developing CAA. Next, we can see that the inflammatory markers were also higher in the CAA group as compared to the non-CAA group. ESR mean for the first star was 67 in the CAA group, at 50 for the non-CAA group. CRP 68, the mean value for the CAA group, and for the non-CAA group lies at 44. The platelet count was also higher as observed for the CAA group and as compared to the non-CAA group. Interpretation, non-CA patients manifested with more clinical signs such as rash, lymphadenopathy, desquamation, conjunctival injection, and oral changes, as our values already indicate. CA patients had less outward symptoms with prolonged fever and presented as mainly as cases of incomplete KD, accounting for 73% of the total patients. Laboratory differences, as already discussed, increased inflammatory markers such as ESR and CRP and thrombocytosis were more seen in the CA group as compared to the non-CA group. Conclusion, patients diagnosed with CA were noted to have fewer clinical features of KD, although persistent fever and raised inflammatory markers were evident. Patients with CA were mostly diagnosed as cases of incomplete KD. Identification of clinical signs and lab parameters suggestive of CA may help in early recognition and prompt intervention. Few recommendations. Current criteria for Kawasaki disease can be modified for early pickup of the disease, and specific signs for CA could be given more weightage for early diagnosis and intervention. The term incomplete KD should rather be replaced by a term indicating more aggressive disease because, as we saw in our study, around 70 to 80% of the cases of incomplete KD had developed coronary artery aneurysms. Thank you.
Yeah, it is good to know that again we are confirming that incomplete KD will produce more coronary artery and a complete KD. And in your signs and symptoms, when you compare it, around 40% of non-coronary group signs and symptoms were less in coronary artery.
Yes.
Whereas ESR and CRP was very high.
Was raised.
That means inflammatory markers are very high. I wonder why signs and symptoms not appeared lesser than the other group. Especially with the ESR and CRP high, indicating that the severity of the vasculitis.
Yes.
So all kind of vasculitis only producing eye congestion, redness of the mouth, etc. good to know and observe that. Do you have any reason for that? When ESR and CRP is high, signs and symptoms are shown less actually in your side.
Sir, one thing we saw in this was that the patients in the CA group were mostly in the infantile age group. So those patients, when they present with fever, they mainly find a doctor, and they presented to us mainly with complaints of fever. So they were diagnosed early, and hence the signs were not present at that time, sir. But during the stay, some of the patients developed those signs. But at the time of diagnosis, they did not have those signs because they mainly presented with complaints of fever, sir.
The difference you have found, are they statistically significant?
Sir, I cannot comment on that, but because I currently do not have stats with me on this. But the difference on the two changes such as desquamation and lymphadenopathy, they seem to be significant as we observed in our study, but I do not have the stats as of right now, yes, sir.
Can you give me recommendation?
Yes, sir. So I know, sir, that was the limitation of our study. The sample size was also less, and we did not have the stats, but the numbers indicated such. So based on that, I recommended something, sir. Yeah, sure, sir.
Thank you.
Thank you, sir.
So coming to the next presentation, I would like to invite Dr. Shahid H. Sayali for his presentation.
Very good morning to all. I'm Dr. Shahid, Senior Resident in Cardiology at JIPMER Pondicherry. So I'll be presenting on my study, Exercise Capacity in Children with and without Coronary Artery Aneurysms following Kawasaki disease and MISC in comparison to healthy controls and the effect of a structured exercise program. So the studies regarding exercise capacity in children with KD and MISC are limited and have shown variable results. So the lower exercise capacity in such children could be related to compromised perfusion during exercise, but it could also be related to unwarranted exercise restrictions which were imposed due to safety concerns resulting in physical deconditioning. So in addition to the inherent risk given by KD, as we have seen, like 5% of patients who were treated also had aneurysms and future cardiovascular events, physical inactivity will compound this issue, putting such patients at increased risk of future cardiovascular or coronary events. So the primary aim of my study was to assess the baseline aerobic exercise capacity of these children with and without aneurysms in comparison to controls using cardiopulmonary exercise testing. And the secondary objectives included assessment of any change in exercise capacity after 6 months of an exercise prescription, and also to identify any abnormalities in myocardial perfusion by stress nuclear imaging. So I included patients more than 7 years of age with history of KD and MISC with and without aneurysms. I included only mild and moderate aneurysms, that is up to Z-score of 10, and they were matched for age, gender and weight. Excluded patients with giant aneurysms with systemic illness impairing their ability to safely perform a CPET, rhythms other than sinus rhythm, LV dysfunction, resting desaturation and resting hypertension. So after the basic data collection and echocardiogram, those patients whose anatomy could not be delineated clearly by echo were subjected to CT coronary angiogram, and then a questionnaire was given to assess the level of their baseline physical activity. Following this, CPET was done using bicycle ergometer, and the primary parameter which I assessed was the VO2 max. And after that, a stress myocardial perfusion imaging was done for the test group who had low baseline exercise capacity with aneurysms. And following this, an exercise prescription was given for the test group of patients for 6 months. And the plan is to repeat CPET at 6 months. The study is actually ongoing. So these are the preliminary results of my study. So there were a total of 17 patients which I could get over a period of 1.5 years, which included both KD and MISC with and without aneurysms, out of which 3 patients had aneurysms and all 3 were males. And all 3 patients had Kawasaki disease. So the LV function was normal for those patients irrespective of the aneurysms. And the primary parameter which I assessed for the exercise capacity was the VO2 max in ml per minute. The mean value for the patients with aneurysm was 747, which was comparable to that of controls. and the VO2 per kilogram was 23.5, which was slightly lesser than 24.5 in comparison to controls, and the METs attained were also lesser, 6.7 in comparison to 7. Though statistical analysis has not yet been done, there is a trend which shows that these parameters are lesser in children with aneurysms. So these were some of the representative images which I've collected. The first row shows a patient who is 11 years old currently with history of KD 2 years back, and he has still like persistent aneurysms involving, mild aneurysms involving RC and LMCA. And the second patient has a moderate sized aneurysm involving the left main, and the third patient has a moderate sized RC aneurysm. And like I said, those patients whose anatomy was not clear were subjected to CT coronary angiogram. And this is the cardiopulmonary exercise testing report which we get at the end of the study. So we can see multiple parameters are assessed, out of which VO2 per kg and VO2 max were the primary parameters which were assessed. And in this case also we can see the child has a VO2 per kilogram of 26.5, which is significantly lower than the normal value of 41.3, suggesting a low exercise capacity. So in all the 3 patients with aneurysms, stress myocardial perfusion imaging was done, and there was no evidence of stress-induced ischemia. And following this, an exercise prescription was given to all the patients, which included 30 minutes of aerobic exercises for at least 3 days a week. So this was as per a Japanese study which was conducted, and also the repeat CPET assessment after 6 months is to be done, which is pending. So in conclusion, persistent aneurysms in KD and MISC were rare on long-term follow-up, and they predominantly involved the left main and right coronary artery. The VO2 max and VO2 per kilogram in KD and MISC patients with and without aneurysms were comparable to that of age, gender and weight match controls. There was no evidence of stress-induced ischemia in any of the patients with persistent aneurysms. The low VO2 per kilogram in the KD or MISC group could also be related to physical deconditioning, which will require a long-term follow-up after an exercise prescription to assess for any changes in aerobic exercise capacity. So the limitations of the study was that this was a single center study with a limited number of patients. So possibly by recruiting more patients over a longer period of time, more meaningful conclusions could be made out. Thank you.
In your study group, both KD and MISC together.
Yes.
So in that case, without coronary artery aneurysm are taken.
Yes, sir.
So MISC cases, all cases with coronary artery dilatation or?
No, actually, sir, I had total of 17 patients, out of which only 3 had aneurysms, and all these 3 were KD patients. None of the MISC patients had aneurysms in my study.
And I think somewhere I saw that irrespective of coronary artery involvement, VO2 was less, right?
Yes, sir. Irrespective of aneurysm status, VO2 was lesser.
How you will explain? Because in the clinical implication, we think that indoor and outdoor exercise for the KD cases to be advised as per this study. So then, irrespective of artery aneurysm, VO2 was less. Is there any reason?
Yes, sir. One possible thing is that physical deconditioning, because as I told, multiple parameters are assessed in the CPET, and one of the parameters is called as the respiratory exchange ratio, which has a cutoff of 1.1. So in almost many patients, I got a value which is lesser than that. So it means that their effort was suboptimal. So but the patient was subjectively breathless or fatigued at the end of exercise. So possibly that physical deconditioning is contributing to the lesser VO2. So, and that is what I want to see after the follow-up, whether that is improving with the exercise prescription or not after a period of 6 months of exercise prescriptions.
One technical question, this VO2, how the computer software is analyzing from
this is yes, sir, this is a bicycle ergometer, so just like a stationary bicycle. Yes, sir. Yes, sir, there is a mask, sir. Mask is kept, and then an analyzer, it is connected to the system. So based on that, automatically at the end of the exercise, the reports are being given, sir.
You have said no evidence of stress in patient with aneurysm.
Yes, sir.
What is the reason? KD and MISC, how did you, they are not uniform form of disease, there is no uniformity basically.
Yes, sir. Actually, I intended to take KD patients only, but since my sample size was limited, I involved all the coronary artery aneurysms, and those who had clear-cut KD were separated, and those who had RT-PCR positive for COVID or previous follow-up cases of COVID were grouped as MISC.
That's
Both combined,
But in the final, yes, sir. But in the finally, all the patients with aneurysms were KD.
You study separately, KD and
Yes, sir. KD and MIC separate.
The second question, there is no evidence of stress with aneurysm.
One thing that all the patients, none of them had giant aneurysm, sir. So possibly because of like a smaller aneurysm causing lesser like stress-induced ischemia. Thank you.
Next. So for the next presentation, I would like to invite Dr. Alfred Thomas for his presentation.
Next, laser.
Yes, sir. Last, sir. Good morning, respected judges and distinguished faculty. I am presenting this case report in front of you titled Kawasaki disease and systemic artery aneurysms. So we were referred in 2021 a 6-month-old boy for abnormal ultrasound examination elsewhere, who was treated elsewhere for fever for 20 days with multiple courses of antibiotics, and the abnormal ultrasound at the end of the treatment, the physicians referred us the child. On probing history, the mother gave history of conjunctival injection and maculopapular rash in the first week of illness, which subsequently subsided. And on examination in our institute, the child had hyperemia over the BCG vaccination site. On examination, the child had normal pulses and blood pressure. Investigations revealed neutrophilic leukocytosis and thrombocytosis with increased inflammatory markers. So a diagnosis of incomplete Kawasaki disease was kept, and the child was subjected to echocardiogram, which revealed multiple giant aneurysms in both sides of the circulation, right side and left side coronary circulation. Because of the abnormal ultrasound abdomen, which showed a dilated abdominal aorta elsewhere, the child was subjected to a CT aortogram in addition to the coronary angiogram, which confirmed the findings in the form of a fusiformly dilated abdominal aorta aneurysm in the infrarenal location, measuring around 1.7 centimeter, which extended up to and included both the internal iliac arteries. There were also aneurysms in the bilateral subclavian arteries, and in addition, the ascending aorta was also dilated. So this is the picture. You can see the dilated LAD aneurysm in the LAD, and in B you can see the aneurysm in the RCA. In C you can see the fusiformly dilated infrarenal abdominal aorta, which is extending up to the internal iliac artery and involving all these branches. In D and E you can see the subclavian artery aneurysms, and E also shows the dilated ascending aorta. So the child was managed with intravenous immunoglobulin, infliximab, methylprednisolone, followed by started him on a course of oral prednisolone, cyclosporin, and also low molecular weight heparin, atorvastatin, and aspirin, with which the general well-being improved and inflammatory parameters also came down. However, the child had persistent mild elevation in CRP to the tune of around 10 to 15. So at the 4th month of admission, the child was again administered a second dose of intravenous immunoglobulin and infliximab. And because of the diffuse systemic nature of the vasculitis, child was given methotrexate as well, weekly doses. And at the end of 2 years, the low molecular weight heparin was replaced by warfarin. This is the present status of the child at 4 years. The photograph is placed with the informed written consent of the parents. and the child is at present asymptomatic. He is being continued on warfarin, aspirin, atorvastatin. The methotrexate was stopped in the last review 1 week before, and the latest echocardiogram shows that the aneurysm in the circumflex had normalized to normal dimension, but the right coronary artery continued to have dilation, and a small aneurysm persisted in the LMCA, and a giant aneurysm persisted in the LAD. So this is the ultrasound abdomen pictorial representation. The last ultrasound showed that the abdominal aorta, infrarenal portion of the abdominal aorta was dilated still at 1.64 centimeter, which is comparable to the baseline dimension of around 1.7 centimeter. In addition, that fusiform dilation extended up to the right and left common iliac artery, and the dimensions of the common iliac also were comparable to previous 1.2, previously 1.5 centimeter now, and left side 1.0 before, 1.3 centimeter now. In addition, there was no thrombus previously, but this ultrasound showed an eccentric thrombus around 9.5 mm in the right common iliac artery. However, the child is asymptomatic. The child does not have any limb claudication symptoms. The lower limb of the right side lower limb, there is no coolness, or there is no pain or tenderness or any swelling in the right side compared to the left side. Because of this, a vascular surgery consult was obtained, and they have, because the child is asymptomatic and the INR is in the therapeutic range, they wanted to continue with the medical management for now, and are not planning any surgical intervention at present. So here I have quoted 2 articles. One is published in Circulation in November 2024. So in this, the participants, there was a survey conducted to the investigators in International KD Registry. So out of the 48 members who responded to the survey, 32 members have experience dealing with systemic aneurysms in KD. And in addition, they also conducted a systemic review in which 21 articles were found with the systemic aneurysms in KD, out of whom 75 children in the 21 articles had systemic aneurysms. So a review of the survey plus the review of articles showed that the risk factors for developing systemic aneurysms were Asian ancestry, male babies, especially infants less than 1 year old, and clinical parameters like giant aneurysms, multiple aneurysms, rapidly expanding aneurysms, resistance to standard treatment, persistent fever, persistently elevated inflammatory markers. These were all the common risk factors found in the review articles, and these were all the risk factors which the investigators in the survey were using to screen for systemic aneurysms elsewhere. The presence of these alerted the IKD or investigators to screen for systemic aneurysms elsewhere. And the most... Sir. This is another article which followed 30 patients from 1980 to 2010, which again showed bilateral and giant aneurysms being a risk factor. And around 50% patients had regressed, but 25% lesions had stenosis at the end of 20 years. The conclusions are 2% of untreated Kawasaki disease patients develop systemic aneurysms. And as I already mentioned, the high-risk candidates, the infants, the male babies, the age less than 1 year, and multiple aneurysms, giant aneurysms, these are risk factors which make the clinician to screen for systemic aneurysms. They can be done by ultrasound, they can be done by MR angiogram, ultrasound, but the most common test done in the studies were CT. And the outcomes resemble that of the coronary artery lesions. Some regress and others persist, but usually the large aneurysms often lead to stenosis. Like the coronary arteries, the fate depends on the diameter in the acute phase.
Thank you. But be careful that this presentation, 5 minutes should be fast. And your voice picture, I should be covered, okay? For the legal
Yes.
issues. And in your case, you have not given a beta blocker, right? Because I know some cases, it's good actually if you give the beta blocker. I saw other drugs and all.
Yes, sir.
Another thing, with the ultrasound itself, you drawn that picture, isn't it?
Yes, sir.
It's not really necessary with the ultrasound itself, you can make out, right?
This is the ultrasound report the radiologist sir had pictorially represented.
All the gradings hospital basis ultrasound should be done not only for that gallbladder enlargement, etc., etc. So with that you will get idea whether arteries enlarged or not. Then we can send for CTCA.
Yes, sir.
Thank you.
So for the next presentation, I would like to invite Dr. Akansha for her presentation.
Good morning, I am Dr. Akanksha. I will be presenting the study titled Assessment of Coronary Artery Abnormalities in Children with Multisystem Inflammatory Syndrome at 1 year of follow-up. MIS-C is a hyperinflammatory condition linked to SARS-CoV-2, first identified in April 2020. Coronary artery abnormalities in MIS-C are reported to be 13 to 26% during acute presentation. Transthoracic echocardiography have been the preferred modality for follow-up the patients with MIS-C, but it has several limitations. CTCA on CT scanners give superior resolution and motion-free images with radiation exposure less than 1 millisievert. So this study aimed to assess the coronary artery abnormalities at 1 year of follow-up in children with MIS-C who had CAs at either initial evaluation or had severe disease at diagnosis. Secondary objective was to compare both the modalities for efficacy in picking up these abnormalities at follow-up. Via this study, so long-term fate of coronary artery abnormalities in children with MIS-C is still unknown, and majority of studies have shown regression in early follow-up. But these studies have mainly used TTE as a primary modality. This study utilizes CTCA as a primary modality of assessment at follow-up. This is a prospective observational study conducted between July 23rd to December 24th. Inclusion criteria being all children with MIS-C at least 1 year back of diagnosis or acute severe manifestation at diagnosis. Exclusion criteria was any contraindication to CTCA or not giving consent. This study was approved by the Institute Ethics Committee also. So inclusion criteria, all the children who were fulfilling the inclusion criteria were approached, and CTCA and TTE was done on the same day. Outcome was assessed using both the modalities, and CTCA was considered as a reference standard. So in children enrolled for the study, total of 24 children were enrolled. Age at diagnosis was 7.4 plus minus 3.1 years. Age of enrollment was mean of 10.1 plus minus 3.1 years. Boys were enrolled around 80% and 20% were girls. Interval between diagnosis and enrollment was median of 30 months, 12 to 40 of IQR. The phenotype of the children enrolled were 33% of MIS-C phenotype, 67% of MIS-C KD phenotype. At diagnosis, around 50% of the children had coronary artery abnormalities, 16% in MIS-C phenotype and 33% in MIS-C KD phenotype. All the children were given immunomodulator therapy at diagnosis. 58% received IVIG plus MP, methylprednisolone pulse. 25% received IVIG, methylprednisolone pulse and adjuvant therapy. 12% received only IVIG and 4% received only methylprednisolone treatment. At follow-up using TTE, significantly decreased Z-scores were found. LMC of minus 0.22 plus minus 1.2 Z-squares, LAD of plus 0.6 plus minus 2.2 Z-squares, RCA of minus 0.45 plus minus 1.44, LCX of minus 0.8 plus minus 0.73 Z-scores. The regression rate of the study was 54.1%, which was showing 67% regression maximum in the LMCA artery, and LCX had no regression. That means either at diagnosis, 2 coronary artery abnormalities were found in LCX, which persisted even after follow-up. In this study, only one giant coronary artery abnormality was found at diagnosis, which regressed to medium-sized coronary artery aneurysm, even at follow-up of 30 months using CTCA. Comparing both the modalities for assessment, Interclass correlation coefficient was 0.75, 0.75 and 0.95, which was statistically significant, suggesting a good correlation between both the modalities. So in conclusion, at diagnosis, 12 children out of 24 children enrolled had coronary artery abnormalities, which were a total of 24 coronary artery abnormalities. At follow-up, these coronary artery abnormalities persisted in 4 out of the 12 children, with a total of 11 coronary artery abnormalities in 24 of the 24 initial diagnosed coronary artery abnormalities. No new CAAs were identified. Total rate of regression was 54.1%. Regression rate for small artery aneurysms was 76.9%, for medium was 50%, and one giant coronary artery aneurysm at diagnosis persisted even at follow-up and regressed to medium-sized aneurysm. CTCA had advantages over TTE in form of better visualization and identification of mid and distal segment aneurysm involving RCA and LAD, and even identifying CAs involving left coronary circumflex artery. I would like to thank Professor Sujit Singh sir, my mentor Dr. Rakesh sir and Dr. Manful sir, and IRA for supporting this thesis. Thank you.
You could have shown one slide for the signs and symptoms produced by this group producing coronary involvement, because you can think that it's like KD-like illness. Whenever the criteria at least 2 plus coronary involvement, definitely I say that triggering agent is RNA virus, SARS-CoV-2, and producing immunoglobulin vasculitis and producing activity like a KD. Because since you are presenting only missing, whether you consider as a KD or not.
Sir, the criteria which was used for diagnosis of the patients were based on the WHO criteria for MIS-C. If that was fulfilling, I have taken as a MIS-C patient only, but the phenotype, yeah.
Those things whether it was associated with this group missing with coronary dilation.
Sir, can you repeat, please?
The signs and symptoms, same thing I repeat. One slide you could have showed the signs
Yes, sir.
and symptoms produced by your group.
Yes, sir.
So that there are coronary dilatation.
Yes, sir.
With the
Phenotype correlation. Yeah, yes, sir. Yes, sir.
Correlate.
Yes, sir. Yes, sir.
What's the message you want to give us?
Sir, all the studies which were done for the patients who were diagnosed with coronary artery abnormalities in patients with MIS-C at diagnosis, even at follow-up we were only doing TT for the assessment. But the children who had either severe disease or had coronary artery abnormalities involving maybe medium or large aneurysms, they should be followed up using CTCA preferably than TT for the regression of these coronary artery abnormalities. Most in children who had severe coronary artery abnormalities or severe disease at presentation. Sir, in this KD phenotype was there in around 6, yeah, I've shown. Of the 67% was KD MIS-C phenotype, sir, and 33% was only MIS-C phenotype in this study, sir.
So for the next presentation, I would like to invite Dr. Vishali Thakur on the stage.
A very good afternoon to all. I will be presenting on the assessment of prevalence of coronary artery aneurysms and IVIG resistance among Indian patients affected with Kawasaki disease. These are our preliminary findings from a multicentric ICMR study. So basically, KD is a childhood vasculitis affecting the coronary arteries, potentially leading to aneurysms. Its diagnosis is made on the basis of a combination of clinical characteristics laid by the AHA criteria. IVIG treatment reduces complications, but some patients have shown resistance. This study assesses the prevalence of coronary artery aneurysms and IVIG resistance in Indian KD patients comparing complete and incomplete subgroups. A total of 80 affected individuals were recruited between March 2024 and December 2024 as a part of the ICMR-funded multicentric study. Recruitment of KD patients from 4 multi-centers was done. Dr. Rajendra Prasad Government Medical College and Hospital Tanda, PGIMER Chandigarh, AIMS Patna and ICH Kolkata. 80 patients were enrolled from 4 different sites, followed by their laboratory parameter evaluation and coronary artery assessment via 2D echocardiography. The percentage distribution of complete KD and incomplete KD patients. Most of the patients responded to IVIG, whereas few patients were IVIG resistant. The prevalence of CAA in KD subgroups, out of the total KD patients, 81% of them exhibited normal coronaries, whereas 19% of them exhibited coronary artery abnormalities. In case of the complete KD group, 79% of them showed normal coronaries and 21 of them showed CAAs. And talking about the incomplete KD patients, 84% of them showed normal coronaries and 16% with CAAs. This is the profile of coronary artery abnormalities in KD patients at our multicentric from the data generated from this study. So the complete KD patients with CAAs constituted the small aneurysms, medium aneurysms and the giant aneurysms, in which 8 showed small aneurysms, 1 showed medium aneurysm and 1 showed giant aneurysms. In case of the incomplete KD, all of the cases were showing small aneurysms. So this is the percentage distribution across 4 healthcare centers in India, in which the majority of the patients were enrolled from PGI Chandigarh. So this table highlights the results from our study, and the IVIG therapy proved to be effective in 87.9% of the patients and 12.08% of the patients exhibited resistance. A significant proportion of Indian patients developed coronary artery abnormalities. So these are my concluding remarks. 18.75% of Indian patients developed CAAs, predominantly the small aneurysms, while IVIG therapy proved to be effective in 87.9% of the patients. 12.08% of the patients exhibited resistance, highlighting the need for alternative therapeutic strategies. Early diagnosis and risk assessment are crucial, especially in differentiating the KD subtypes. Larger studies are needed to optimize the KD management and reduce the cardiovascular complications in KD patients. Thank you, everyone.
You have stratified the resistance in different centers, between different centers. You have said 18.75% resistance. Is there any difference from center to center in experience?
Because the previous study presentation, incomplete KD had more coronary.
Study the complete KD had more coronaries.
Institutional variation, that's what sir asked. Is there any
Incidence of aneurysm almost same in complete and also in incomplete.
So yes, sir.
If I am not wrong. You have not done the statistics?
No, sir. So we just went with the percentage. Yes. Okay, thank you.
So for the next presentation, I would like to invite Dr. Anup Kumar for his presentation.
Next is
So good morning everyone. Sir, may I start? Good morning everyone. Today I am going to talk about the exploring genetic complexity in the Indian Kawasaki disease patient using the exome sequence, whole exome sequencing approach. This is the preliminary finding from a multicentric ICMR study. So this is a brief introduction about the Kawasaki disease. We have already heard from the 3 to 5 days the clinical symptoms of the Kawasaki disease, which include the conjunctivitis, fever for more than 5 days, strawberry tongue, rash, swollen hand, and cervical lymphadenopathy. And the diagnosis is based on the laboratory finding and laboratory finding mostly, and the CT scan and the two-dimensional echo, and the treatment possible intravenous immunoglobulin and the aspirin. So we have already listened about the incidence pattern from the 2015 to 2020, that the incidence of the Kawasaki disease gradually increasing in the Indian context. But the challenges are the most challenge in the Indian population is there is no current treatment strategy depend upon the harnessing anti-inflammatory via the use of IVIG and aspirin. And the unknown etiology, also the genetic predisposition is also there, that, and the viral infection also there, that makes more difficult to treat. So there are the genetic complexity of the Kawasaki disease, which include all kind of the like calcium signaling path in the pathogenesis of the Kawasaki disease, gene that influence the immune system. Also there are also gene which influence the cardiac function. So in order to see all the complexity, we have designed the research question: which genetic factor and the novel loci are implicated in the development of the coronary artery abnormality and the intravenous immunoglobulin resistant in the Indian children with the Kawasaki disease? How does the regional distribution, prevalence, and identify risk factor of the KD cases across healthcare center contribute to understanding of the epidemiology and risk stratification of the CA in the affected children? So objective is to identification of genetic variant for the development of the coronary artery abnormality in the Indian children with the KD. So for doing that, we have done the genetic profiling the Kawasaki disease patient and identify the variant associated with the CA, coronary artery abnormalities. So to do this, we have done the patient enrollment for the around 4 different centers from the India, and we have this enrollment is from the March 2015 to March 2024 to December 2024. We have total enrolled 107 patients, but for whole exome sequencing, we have only taken three patients which have the small aneurysm, and we also taken the 2 healthy control for the comparison study. So we prepared the whole exome library preparation, done the whole exome library preparation, and then this is the generalized workflow for the whole exome library preparation, where the blood is DNA sample extracted from the blood sample, and the DNA is then provided to the unique index are provided to the each DNA sample, and then the exome library are enriched and the sequence done on the Illumina exome platform. So this is the workflow for the prioritizing of the variant from the whole exome study. So we have done the quality check for all the raw variant, and then the non-synonymous variants we have included in the study, and the common variant have excluded from our study, which has the minor liver frequency ranges from the 1.2, which is in the minor liver frequency we have considered only 1 to 5%. So after getting the exome frequency of the variant, we have done the pathogenicity prediction based on the SIFT, CAD, and Polyphen2 and mutation tester scores. And then we have also applied the selective gene filter, which include the 64 gene related to the Kawasaki disease. So we also done the human phenotype ontology term analysis, and we have selected those term like redness of the eyes, fevers and fevers, and the cervical lymphadenopathy. We also include that terminology in our analysis. So but we have found from the result is that the total variant in each patient ranges from the approximately 300 variant we have found in the raw CSV file from the each whole exome study. So only non-synonymous variant have been carried out in the further study. To the non-synonymous variant, we have done the minor leaf frequency checking. We have put the threshold criteria. We have we have only taken the 1 to 5% minor leaf frequency, and then check the in silico prediction. And based on the in silico prediction, we have found out the patient one have the mutation, the ABCC4 gene, LEMO7 gene, and the patient 2 have IL6 gene, and the patient 3 have HLA-DQB1 mutation, TTN mutation, SMAD3 mutation, and MB3 mutation. But none of these variants have the likely pathogenic or pathogenic nature based on the American Council of Medical Genetics guidelines. So these are the genes and their full description and the variant detail, but many of the variants are related to the myocardial function, and only one variant which has shown in the myocardial infection in the KD, but other variants are not found in the anywhere in the world. So, but we have concluded from this study, whole exome sequencing can be used for identification of the rare and common variant in the KD patient with a filtering approach narrowed down in a few candidate genes: ABCC4, LMO7, IL6, HLA, DQB, TTN, SMAD3, and MM3 are well identified in the patient but not in the control, suggesting a potential role in the Kawasaki disease susceptibility. Current findings indicate a potential genetic importance in the Kawasaki disease, but further validation are needed. That this validation include the polygenic risk scoring and also the functional analysis. Our preliminary analysis suggests ethnic difference and heterogeneity of the Indian population as compared to the national population for genetic susceptibility of the KD in India. Therefore, we need to do a larger study for variant identification. Clinical implications are the study highlight the potential genetic target for the future KD research and personalized treatment strategy. Identify variant from the large sample size from multiple centers from different geographical regions generate a high potential to new approach for treatment possibility. So these are thank you.
You have got 6 or 7 genetic abnormality.
Pardon, sir?
Number of genetic abnormality you have got 7?
Sir, 7 genes, sir.
7 genes.
Yes, sir.
And how do you reach the target? So many genes.
Sir, we have in the filtering approach, I have taken the 64 KD related patient, and to these 64 patient, I put the in silico prediction based on the protein conserved region and also the population frequency score threshold. So based on that, I reached to the 7 genes. And also these variant are in the preliminary study. I need to follow the polygenic risk scoring method and statistical analysis method for further screening in the larger cohort.
All 3 groups are different gene identification. One is ABC, in that side, matrix and laboratories, among 3, all are different. So, clinical implication, how
Sir, the clinical symptoms include some of the patient include the 4 complete 5 symptom. Like when I was putting when some symptom like redness of the eyes is not in the present in one patient, or cardiac CA not complete CA is not present in the some patients. So when I putting the SPO term in the my analysis, though that those variant are excluding from this analysis.
Thank you.
Thanks.
So for the last presentation and for this session, I would like to invite Dr. Dev for his presentation.
Can I begin? Okay. So, very good afternoon, everybody. Today I'll be presenting a case report of Kawasaki disease. So our index case is Mr. H, who's currently 19 years old, but he has been under our follow-up since 2014 when he was 8 years of age. They hail from Bangalore. So in 2014, he had an acute episode of fever with a gastrointestinal focus, for which on day 4 of illness, he was admitted at a hospital in Bengaluru. During the course of hospital stay itself, he was noted to have the classical features of Kawasaki disease in the form of a macular rash, conjunctival congestion, cervical lymphadenopathy, and red lips with a strawberry tongue. And investigations at that time had shown anemia, neutrophilic leukocytosis, progressively increasing platelet count, and elevated CRP. So on day 8 of illness, KD was considered, and he received IVIG at 2 grams per kg on day 8. At that time, a 2D echo done had shown an RCA dilatation. However, even after more than 36 hours of completion of IVIG had elapsed, his fever remained persistent. So on day 12 of illness, he was given infliximab at 10 mg per kg, and he was also noted at that time to have a periungual desquamation. Even after receiving IVIG, aspirin and infliximab, since his fever remained persistent, his platelet count was increasing, his inflammatory parameters were elevated. He was given a second dose of IVIG on day 17 of illness, and after that he was referred to our institute where he reached on day 21 of illness. By that time, his fever had become passive. So in our institute, first the 2D echo which was done on the 22nd day of illness had shown diffuse dilatation of left main coronary, left anterior descending and right coronary artery. And on day 25 of illness, his first CT coronary angiogram was done at the baseline. That had shown a diffuse dilatation of the LAD with a giant coronary artery aneurysm in the proximal segment. And in the right coronary artery also, he had a diffuse dilatation in the proximal and mid segment, and one aneurysm of 4.2 mm in the distal segment. So with this, he was started on aspirin and low molecular weight heparin, and subsequently the low molecular weight heparin was converted to warfarin and statins were added. In 2017, intermittently they kept on following up in Bengaluru, and every once in 3 to 5 years they would come to our center for follow-up. So at 2017, a repeat CT coronary angiogram had been done that had shown a fusiform coronary aneurysm in the proximal and mid RCA, saccular coronary aneurysm in the distal RCA, and dilatation of proximal LAD with a coronary artery aneurysm in the mid LAD. However, no evidence of thrombosis was found at that time. Since the giant aneurysm had resolved to a moderate aneurysm, his anticoagulation was stopped by around 5 years of treatment, and he has been continued on aspirin and statins till now. His latest follow-up with us was in January of this year. So at nearly 10.5 years of illness, a repeat coronary angio by CT was done. In that, the proximal LAD was dilated, and there was a calcified fusiform aneurysm in the mid LAD, which also had a thrombus which was causing 40 to 50 meters of lumen diameter reduction. And the RCA, the proximal and mid RCA was dilated, and a peripherally calcified fusiform coronary artery aneurysm was seen in the proximal RCA. However, there was no thrombus there. We also did a cardiac MRI to look at the heart function and physiology, in which the fusiform aneurysm in RCA and LAD was confirmed, the LV function was preserved, and no fibrosis or scar were noted in the myocardium. Clinically, he is not having any symptoms currently of exercise intolerance or orthopnea or paroxysmal nocturnal dyspnea. For now, we have planned that we would continue aspirin and statin for him. He has been back referred to Bengaluru, where he is going to undergo stress test for inducible myocardial ischemia, and based on the results of these tests, we will decide whether he needs any intervention or not. So these are my take-home messages, that Kawasaki disease is an enigma, and risk of complications reduces significantly, but not entirely with timely treatment. In those years, we were not very enthusiastic with steroids, but now, if as per the KD AHA 2024 protocol, if we can intensify the treatment of resistant KD with steroids and cyclosporine at the onset, we may be able to reduce the coronary artery aneurysms and sequelae, and CT coronary angiography at baseline and in follow-up of children with KD who develop CAs has an important role in picking up complications like thrombi in this case. I would like to thank all the faculty members, residents, PhD students and staff of the Pediatric Allergy Immunology Unit and Professor Manfool Singhal, the lead of Cardiovascular Imaging, Department of Radiodiagnosis and Imaging at PGI. Thank you.
So despite of intensification, coronary progression, we cannot provide.
Yes.
Intensification, what are the drugs you tried, the cyclosporin, other drugs, all?
Sir, this child was diagnosed with IVIG-resistant Kawasaki disease in 2014. At that time, he had received first dose IVIG, followed by infliximab and a repeat dose of IVIG. That time, steroids or cyclosporin were not very prevalent in treatment of resistant Kawasaki disease. However, now AHA 2024 guidelines have upfront told that they have given the option between infliximab, second dose of IVIG, steroids and cyclosporin. And in our center, if the child has any high risk features or significant abnormalities at baseline or IVIG resistance, we are hitting it with infliximab, oral steroids as well as cyclosporin right at the onset itself.
Some of the oral medication also can be tried. I have seen one publication from the Toronto Institute that doxycycline is really helpful sometimes because it inhibits the MMP, matrix metalloproteinase 9, MMP 9. And another one is my own study, the animal study, very nicely antioxidant drug because it scavens the singlet toxin. So vitamin C, A and E, that also is the website. If you give orally, because you don't need to be approved also. And very next day, after giving vitamin C and all, fever will come down. So some oral medication also can be tried as an intensification. Anyway, it's a good observation. Thank you.
Thank you.
So for the next session, after this oral presentations, I would like to invite Professor Sujit sir to chair the session for them.
Good afternoon. So for this pre-lunch session, we have Professor Tapas Sabui, who is an alumnus of this institute, and he's presently at the Shantiniketan Medical College, Bolpur, West Bengal, and he would be talking on the current status of steroids in Kawasaki disease.
Good afternoon, everybody. Thank you, Sujit Singh and Dr. Rakesh and his entire team for
that you need a longer dose, short-term benefit is there. Another term they are coined, that is a high risk. With this 2017 AHA guideline has, the benefit is usually moderate in all situations. And subsequently, what is the multiple publication in 2023, there was a publication showed when given in acute phase of corticosteroid appeared to reduce the risk, reduce inflammatory short-term benefit is there. Multicenter prospective Japanese prednisolone therapy are an effect similar to those in race. So then thereafter coming out that in high risk group there is a beneficial effect of corticosteroid. So in 2017, the AHA recommendation for adjunctive therapy in primary treatment, so the single dose clearly said methylprednisolone should not be administered with IVIG as routine primary therapy for patients with KD, and may be considered administered longer course corticosteroid may be considered in high risk patient. This may has disappeared in 2024 AHA guideline. Intensification, so they have now counted as a high risk patient who are high risk, baseline coronary artery G score greater than 2.5, infants less than 6 months, and high risk category using SON risk category where age, G score, Asian origin and CRP are the pointers, whether more than 3 they are according to them, it belongs to a high risk group. So high risk means this group. 18% of infants less than 6 months, their G score increases by 8 weeks, within 8 weeks of diagnosis, even despite of timely treatment with IVIG, and infants of 6 months have 5 times risk, with the first 10 years, then 5 times more likely to develop G score, more than 2.5 than in children more than 6 months of old. So children with less than 6 months are at high risk, greater than 2.5 is at high risk, and the SON score, the high risk SON score is there, then they are considered as a high risk. So this group needs an intensification of therapy. That now this is the AHA current guideline where they have the intensification, their position, current position of corticosteroid is in the intensification of therapy. And 2 forms of corticosteroid can be used, is prednisolone and methylprednisolone. Corticosteroid is, according to race, it is given 2 milligram in both situations, 2 milligram per kg per day. It is every 8 hours, according to race study, and every 12 hours. In both situations, maximum dose 60 milligram, 5-day course, and still it remains, people subsides another hospital, then per like 2 milligram per kg every 8 hours, slow tapering for about 15 days, maximum 30 days, once CRP is normalized, and the reduction is 5 by the half every 5th day. So this is the current recommendation, and the current recommendation is that means it should be used in high risk children. It is as its position currently is intensification. Both prednisolone and methylprednisolone can be used as IV. In our country is IV methylprednisolone easily available and cheap. So we have to adopt this to the best of my knowledge, and that can be, and you have to use the corticosteroid for a longer period of time. So other intensification agent is infliximab and etanercept we are using, we have discussed in detail in the last 2-3 days. So points to be kept in mind, the caution that data is from randomized control trials are lacking. Many of the studies are retrospective in nature and small numbers. This study must be interpreted with caution. Still, the Dr. Tomoaki Kawasaki said on the day 1 that needs to be interpreted with caution. Still, it is there. And prospectively randomized study with uniformity in dose, nature of drug, G score, and absolute value is required. So take home, corticosteroid is a safe drug in acute KD. Confirmed short-term benefit is seen in all studies. High risk should receive as it a primary intensification therapy. Single dose is not calprotective. A prolonged course of only calprotective. With this, I would like to thank you all for presenting.
Thank you, Dr. Tapas, for the comprehensive review of a contentious topic. So,
questions for Dr. Tapas. the practice in various centers across the country? Manjari?
So as Sir said that it is the most used and the most abused drug. So prior to 2016, we were also not using steroids and we were scared of the steroids, but we were using them in Kawasaki shock syndrome and in Kawasaki associated with Pediatric activation syndrome. But post-race trial, and we did a little study and looked at our own retrospective data and tried to see which children were resistant, and then we started using steroid as soon as we, if it's an infant and has a coronary artery score of, Z score of 2 or more, we upfront intensify now.
Since how long you are using?
From 2017. So we are now using this from 2017 onwards.
Is that your first drug?
No, sir. Of course, after IVIG.
No, after IVIG, the first drug that you use is
steroid, 2 milligram per kg.
So you prefer that to infliximab?
Yes, sir. 2 milligram per kg, and initially we were using infliximab. Initially, pre-2017 we were doing this. We were using IVIG, then infliximab, then second dose or a second dose of IVIG, and then infliximab. But post-2017, we are 17 and onwards. We are using IVIG, intensifying upfront with 2 milligram per kg, methylprednisolone in 4 divided doses or 3 divided doses intravenously for the first 3 days at least. Once the child is afebrile, then we switch to oral prednisolone in 3 to 4 divided doses, again 2 milligram per kg of prednisolone equivalent, and then once the CRP is negative, then we start tapering like how the race trial tapers rapidly from 2 to 1.5 to 1 to 1.5.
Continue for how many days?
For about 3 to 5 days each taper, so about 3 weeks or so. And in some children we are required to give steroids a little longer time, and in some children we are required to give other drugs like infliximab also, or cyclosporin also, and we've fallen back on you for all of those difficult cases now. We've not used anakinra in any of our patients so far.
What is the experience of South India?
For the last 4 years, we are giving steroids like acute therapy. But we give it 2 mg per kg methylprednisolone till the CRP normalizes and child becomes afebrile. At discharge, we give oral prednisolone, OD dose of 4 to 6 weeks. Till that,
before 2017?
No, you would use it in selected patients?
Yeah, only on selected patients, like infants who have aneurysms and diagnosis, we give IV steroids. The same infants and who is having aneurysms, who presents late, beyond 10 days, we give IV methylpred pulse, 30 mg per kg per day for 3 days, followed by oral steroids.
Suppose a child with Kawasaki disease is not admitted directly under you, but in some of the other units. Are those consultants also open to using steroids, or?
So in such situations, we will take over the patient because they are hesitant to give the therapy that we tell. They are okay for IVIG. So nowadays, we insist them that if it is an infant with KD, we take over the patient directly. So normal other KD, we will tell them to give IVIG. Any additional therapy we wish to give, so they will also are ready to give the patient to our unit, so we will take over the patient.
So in case of resistance, what was your protocol?
So resistance we give infliximab. Like infants, we give 3 drugs. So resistance we give infliximab and steroids. So for the last 3-4 years with the augmentation, I think the rate of resistance have significantly dropped. In the last 3 years, I have not seen any IVIG resistant KDs. That's also, I think, true with regards to many centers. Even I spoke with Sumam Advance. She is also not seeing any IVIG resistance for the last 5 years.
Because you are preemptively.
Yes. That's true, sir, actually. And the rate of regression also, though it is not published, we see that the rate of regression of aneurysms are also a bit faster with this therapy. The only concern what I reviewed with the paper is that the development of late coronary aneurysms in the vessels which were not having aneurysm at initial diagnosis, maybe few decades later with initial use of corticosteroids. There was one paper, one of the risk factors for late coronary aneurysm is usage of steroids in the initial diagnosis. And over the last 3 years, I spoke with ma'am as well as Hamada sir also regarding their hesitation to start steroids in Japanese population. Till now, they are a bit hesitant to give steroids upfront. The reasons they are a bit hesitant only. They are not
the age studies from their country.
But it's not like pulse and all they give. So yesterday also she presented their experience. So it's like they are not so okay with steroids. So the reason, I don't know, maybe also.
Other centers, Dr. Sajid, would you?
Since I in the assistant grade, previously we said that second dose of IVIG, but now we strongly prefer for infliximab and steroid, and not the second dose of IVIG.
Preemptively.
Yeah.
Dr. Shivpuri, Abhay?
Sir, similar, depends on the high risk or not. So I would upfront give IVIG plus the raised protocol if there is an infant with a Z-score of more than 2.5. Infant definitely, but if there is no other risk factor, only in those cases I would only use IVIG and aspirin. But the more we have used primary intensification, our experience also has been that the resistance is much lesser. Especially as I'm working in the private setup, the cost of the second IV is a big issue. So I would most often use steroids rather than now.
Sandesh, how often are you using steroids?
At our center for primary intensification, we are using infliximab. And if child has aneurysm, we use prednisolone 2 mg per kg. Till the CRP is negative, then we taper off it in next 2 to 3 weeks. And the factors which we take into consideration for intensification, one is age, child is infant, and second is the dilatation and coronary artery aneurysm.
Supreet?
Sir, in our center, in all infants, we will give infliximab and IVIG. And if dilatation is there, then recently we have said from this year onwards, we are giving all the food. We are cyclosporin also we are giving. If there is dilatation.
It is your current practice.
Yes, sir.
5 years back, what was the practice?
5 years back,
you are not there.
So I think what Dr. Tapas has highlighted, so some bit of it has percolated down in clinical practice as well. So we are now more open to using steroids. So the flavor varies. Some centers use oral, some centers use parenteral, but I think all centers now are much more liberal, and that was I think the message that Dr. Tapas also wanted to convey from his review. So with this, we thank you, Dr. Tapas. We move on to the second presentation, and this will be by Dr. Reva Tyagi. So this is KD in older children and adults. Dr. Reva is again an alumnus of this institute. She did her MD and then recently she completed her DAY, and she is working in Chandigarh.
Good afternoon, everyone. I thank my alma mater and the organizers for giving me this opportunity and to be back here as a guest faculty is quite surreal. So my topic is Kawasaki disease in older children and adults, and it is not just a kid's disease. I think we all know by now that adult onset Kawasaki disease is rare, but it is there surely. However, it can still have lasting and devastating complications. So, but what is the cause for this misdiagnosis? Is that usually treating physicians do not consider it as a differential diagnosis when treating these patients. And to back it, there is not much literature. So, also one reason for misdiagnosis is that it has been observed that these symptoms are not as clustered in older patients as they are in children. So during the illness of, let's say, 10 to 12 days, these symptoms come and go. And probably by the time they do present to the treating physician, most of these symptoms are absent. And historically, patients sometimes are not able to tell these symptoms. So that is probably the two main reasons why adult or older Kawasaki disease is being misdiagnosed. So if you look at the incidence, most of these studies have reported in their cohorts the incidence to be somewhere around 1 to 1.5%. There are two studies. One is by Kai et al., where actually they have considered children of more than 5 years of age. So their incidence was as high as 9%. And there is another study which I will discuss subsequently, where they have found the incidence to be around 6%. But more often, and most cohorts have the consensus, and even in R that I'll present, the incidence is somewhere around 1 to 1.5%. Now again, this incidence could be more because most of these patients, as I said, are probably not being diagnosed on time. So this is a study from Canada, including Dr. Brian McTrindle. So they actually studied the patients of Kawasaki disease at both the extremes of ages, that is in the infants less than 1 year of age and the older children. And they considered 9 years and older as the older patients, and they found that their incidence was around 6%. What they concluded in their study was that these patients were more likely to have coronary artery abnormalities, both the extremes, and they did not have, unfortunately, all the classical features. So they were mostly incomplete KD, and probably the reason why the duration of diagnosis was quite long. 12 days was their median diagnosis, but it was longer. And these patients, since they were presenting quite late, they were less likely to receive IVIG because probably the disease had passed, the acute phase reactants had normalized, so they were not receiving IVIG, and those who were being treated, they were not responding just to IVIG like we discussed, so they were more likely to receive steroids, probably because anyway this age group is more likely to have coronary complications and cardiac complications, and secondly because the diagnosis was delayed, so they were in a stage where the coronary complications had already set in. So this is what the Canadian group discussed. So another big cohort was from the French, and they collected the retrospective data of their patients of Kawasaki disease who were 18 years and older. So they found 43 such patients, and the median time of diagnosis in these patients were also 13 days, and the longest duration what they noticed was 21 days. The symptoms were more or less similar, but if you see the cardiac complications in these patients were close to 50%. And 1/4 of these patients had coronary vasculitis, and 1/5 had coronary aneurysms. So treatment was IVIG and aspirin. However, 4 of their patients they reported had myocardial infarction, but again, they were not treated with IVIG on time, probably because they presented late, and by the time they did present, the complications had already set in. So again, the conclusion that the damage was lower in patients who had received IVIG upfront, but because of the long duration of diagnosis, these patients tend to develop coronary abnormalities. So the trend of diagnosing adult KD in their cohort, if you see, peaked somewhere around 2005 and 2006, but has gradually picked up from the year 1992 to the last when this study was published in 2015. So this is the retrospective data from our own center, 10 years of data from the year 1994 to 2019. So again here we included patients of 10 years and older and found around 46 patients who fit this category. Again, median age of diagnosis was 11 years and the oldest patient was 30 years old, and in the French cohort the oldest patient was in fact 68 years old. The median interval from the onset of fever to the diagnosis was again similar as in other studies, that was 12 days, but the longest was reported as 30 days. 8 patients out of this presented with hypotensive shock, so KD shock syndrome, and coronary abnormalities were noted in 13% of these patients. The conclusion again drawn from this retrospective data was that the diagnosis is delayed, and so these patients are at risk for developing coronary artery complications more frequently. Again, if you see the trend of diagnosing older children with Kawasaki disease has steadily been increasing, probably because of the increased awareness now, and we know that it is not just a kid's disease. So profile of Kawasaki disease in adolescents, is it any different? This is a study from Indonesia, and I just want to highlight here again that the coronary artery dilatation percentage, what they report in children more than 10 years of age, was close to 50% again. So just a tangential discussion on adult or adolescents with Kawasaki disease. So this is a long-term health outcome in young adults after Kawasaki disease. So these patients have actually suffered Kawasaki disease in childhood, and this Jane Burns group actually did a questionnaire-based study. All these patients were 15 years or older at the time of the study, and these patients with coronary artery aneurysms reported a lot of complaints like chest pain, palpitations, shortness of breath as was expected, but they also found that patients who did not have coronary artery aneurysms also did not give a very favorable overall health outcome. So they felt that they were not as well as the control group. So control groups were their own residents who had not suffered Kawasaki disease in childhood. So this is one aspect of Kawasaki disease in the older population, in adolescents and probably adulthood, that they have a lot of comorbidities even if the Kawasaki disease happened in childhood. Also, another observation that they made was there is an increased prevalence of allergies to medications and eczema in patients who had Kawasaki disease, and this has been reported in some Southeast Asian cohorts also. The cause nobody knows, but this is one significant observation. What a pertinent point that they pointed out was that there is a limitation of echocardiography in adults because the window is not adequate because of the lung shadow. So probably CTCA could be incorporated as a screening modality in adult patients, because otherwise coronary arteries are likely to be missed in this population. So these are the symptoms that these patients complain. So palpitation, leg swelling, shortness of breath, leg pain with walking, chest pain, hypertension, migraines, and even ADHD in patients who had suffered Kawasaki disease. So these patients, mind you, did not have coronary artery aneurysms, because it is quite expected for these symptoms to be in patients who have aneurysms, but this is the KD cohort that did not have aneurysms. So probably there are some long-term sequelae even in patients who apparently have no coronary artery abnormalities. So this is another report of patients of Kawasaki disease adolescents. So basically, I just want you to focus on this. The patients 13 years and older were around 11% in their cohort, and they have divided these into two groups, the ones that came upfront to their center and the ones that were referred. So the coronary artery aneurysms were more in patients who were referred, highlighting that the more the delay in diagnosis, more the incidence of coronary artery abnormality. So I'll be discussing two case reports. This is from RG Medical College, Kolkata, published into 2021. This 19-year-old female had a history of fever, received multiple antibiotics, and the rash and other symptoms probably got missed. So when she peeled, actually the diagnosis of Kawasaki disease was considered, and she was given IVIG and aspirin, and luckily she did not have any coronary artery abnormality. So this pediatric unit? Yes, sir, pediatric unit, sir. So this was a good save, I would say. And this is one case that we admitted and we published. So this is a letter to editor. So he was a 12-year-old boy who presented with history of prolonged fever and acute epigastric pain. So when he presented to us, we actually had admitted him because of pyrexia of unknown origin, because he was not responding to any antibiotics. So when the history was probed, he came up with a history of redness of eyes, rash, and some photos that he showed of tongue. And by the time he did present to us, he was actually peeling. The echo was normal. You can see there was pancreatitis, and he was already peeling. So we were able to give him IVIG and aspirin, and his pancreatitis resolved. So because these older patients usually have some varied presenting manifestation, it usually misleads us into treating them as infections probably. But this boy was lucky. Despite having a prolonged course and delay in diagnosis, he did not have any coronary artery abnormalities and is doing well now. So this is one clinico-pathological case that was discussed in our CPC. So this was a young boy who had presented to the adult ER. He had history of fever vaguely and presented in loss of consciousness. He was found to have bioventricular failure, and a possibility of an MI was considered. So histopathology was performed, partial autopsy was performed, and the clinical diagnosis at that time was kept as viral myocarditis because there was fever and there was cardiac involvement, there was MI, because nobody could believe that a 19-year-old boy could have anything but that. But so when the CPC was being discussed, so one of our colleagues suggested a possibility of Kawasaki disease in a young boy who had coronary artery abnormality. So the pathology colleague presented that there was a thrombus in the right auricle, the valves were normal. There was extensive fibrinous pericarditis and myocarditis, and the coronaries demonstrated extensive disruption of internal elastic lamina, and the PCR for the infective workup was all negative. This child had received IVIG, but that they gave keeping a possibility of viral myocarditis. However, this child could not make it. So then this case got published, and it is, I think, a lesson for all of us that in any young adult with no prior comorbidity, we probably should always keep Kawasaki disease as a differential. I'll just discuss the management. I will not go into the details. I think that will be discussed in another presentation. What I want to highlight is that how do we know that a given patient has an atherosclerotic coronary artery disease or is suffering from CAD. So basically it is, the mechanistic processes are different. So the presence of aneurysm with a high thrombus burden and a patient, again, a young patient who has no prior comorbidities, KD should always be thought of. And the presence of proximal CAAs with focal circumferential calcifications without significant irregularity or eccentricity should suggest KD and not atherosclerosis. So I'll just leave you with the thought that these days we are seeing that young MIs have become very common. Are some of them missed KDs? Thank you.
You quoted a study by Dr. Advani. So he follows a very large cohort of KD in Indonesia.
Yes, sir.
He's one of the most experienced physicians in Southeast Asia for Kawasaki. Okay, Reva's presentation is now open for comments. I'm sure many of us would have had this opportunity of diagnosing KD in adolescents or sometimes even in adults. The problem is that many of them don't accept the diagnosis. At least that has been our experience. They may not accept the diagnosis at all. Murugan?
It's correct that the patient that you have showed from West Bengal had fever and received multiple courses of antibiotics and suddenly had a Vasculitis English. The closest differential that everyone will offer is a SJS and then spectrum of illness, especially if the aneurysms are not being. But fortunate is that some of them also receive IVIG at 1 gram per kg, and most of the dermatology or medicine
right, for 10.
come out of the illness.
Yes.
Tend to happen.
Yeah.
Moreover, that
Dr. Tapas, you were saying something?
They don't accept that there is a disease.
That's right.
Even the cardiologists, they don't, simply they don't want to accept.
Because these adult population are seen by the physicians, not the pediatricians. So they are well, not aware about this condition.
Actually, I think they will start accepting it when CTC is showing the coronary calcium. Only then probably they will accept it.
But if an adult or an adolescent being managed by the internal medicine unit, if you diagnose KD in them, there is lot of resistance to the
I got opportunity, but they invited me because probably some of them, junior most was there, maybe he was my student. No, he was not my student. Just junior to me, but he invited a prolonged fever, admitted with so the ECG changes and probably exfoliation. I can't remember the probably exfoliation of skin early symptom. So he suspected fever is not responding. All tests are done that are found abnormal. So you please see the patient. That I got a call. And that was I got IVIG and it improved. That and coronary artery initially was abnormal and subsequently the stent was improved. So that was the only time I got the call from them for to see that the patient. But adult cardiologist specifically I told them, they didn't accept that, they didn't believe that there is such a disease can exist.
That is a usual experience.
I think only the CT scan can help, that this will not occur with other forms. CT calcification maybe.
Probably, yes.
I can recall 3 patients in the age group 25 to 30 years that we have seen. The first patient in the late 90s referred by the dermatologist and they diagnosed Kawasaki disease. So, but the parent did not accept the diagnosis and they took the child away. The other 2 patients, they were admitted in our unit and they received treatment. So these were the oldest patients of KD that we have had the chance to see. Any other experience from other centers? Delhi, Jaipur, Tanda, Vellore.
So the patient came to us, but still it was very difficult to manage. And this was 2014, 13. Head Department of Pediatrics.
Next talk, this will be on surgical intervention for coronary artery revascularization.
Mr. Chairman and ladies and gentlemen, I greatly appreciate your opportunity to speak at this session. The first talk about indication and timing for coronary artery bypass grafting in this population, and second is about result of CABG from Japan. This slide shows supporting graft to the left anterior descending artery. SPG was patent in the red period, although number is limited. Internal thoracic artery graft to the LAD is shown. Ideal graft will be the graft would be patent more than 20 years. The gastric troika GIAN graft to the fourth posterior branch of the right coronary artery is shown. In the 6 years old, the coronary angiogram was done 11 months after operation. Composite graft with a radial artery are shown in this slide. In a 70-year-old male, Y grafts were performed. In the left, it was angiogram 3 months after operation. In the right, it was CTA angiogram 1 year after operation. The number of graft material is shown in National Survey of 2004. In 1970s, SPG was used, and the use of ITA graft was started in 1980s. Although the number of DA was limited, the use of radial artery was increased. CABG for multivessel is shown. The operation was performed in a 12-year-old male at 1980s by Kitamura. What is the purpose of CABG? It is improve myocardial ischemia. It is not prevention of acute myocardial infarction. The prognosis may be improving, and quality of life may be improving. In the previous study, 30-year survival rate after myocardial infarction was 49%. This compares with a 25-year survival rate after CABG of 92%. Coronary revascularization is treatment, and role of antithrombotic therapy is prevention. In indication, it's important to evaluate myocardial ischemia. One is symptom, and another is findings of myocardial ischemia in examination. Significant coronary stenosis don't always indicate existence myocardial ischemia. There are CABG and percutaneous coronary intervention in coronary revascularization. CABG is another route, and PCI is dilation of coronary artery. Therefore, the optimal time for intervention may not be same. There are some factors for decision of coronary revascularization. Both medical factors and social factors are important. In this population, evaluation of myocardial ischemia is very difficult. To establishment of CABG, some evaluation are needed. In the vessel is graftable. There is a competition between native flow and graft flow. The degree of myocardial ischemia should be evaluated. Myocardial viability is also evaluated. Is complete coronary revascularization needed in this population? It remains unknown. The next talk is about indication and timing for CABG in this population. No hurry, find the optimal time for each patient. Treatment of acute Kawasaki disease and coronary artery lesion caused by KD has improved markedly in past half century. About 50 years after first report of KD and coronary artery bypass grafting in this population, the knowledge about the background characteristic and outcomes of patients who have undergone CABG after KD is useful in the future for the long-term management of patients with severe coronary stenotic lesion due to KD. The incidence of cardiac event in patients with bilateral giant aneurysm has been significantly higher than that in patients with unilateral giant aneurysm. We often experience a delayed flow of giant aneurysm immediately after acute KD. Is there a significant stenosis or myocardial ischemia in this case? There are some characteristics of coronary artery lesion caused by Kawasaki disease. One is the morphological characteristic, and the second is end cell involvement within 1 year after the acute KD. This case had CABG to the LAD at 10 years old. However, the graft became occluded, and she had an acute myocardial infarction after that. The left angiogram at 20 years old shows giant aneurysm with localized stenosis. After 6 years, the LAD was occluded and asymptomatic. The left angiogram shows occluded graft. After the occlusion of the LAD, the graft was reopened. Functional occlusion of the graft was found due to competitive flow between the native artery and graft. In the same patient, CAG are shown. 21 years after the onset of KD, RCA was asymptomatic locally occluded. This shows a 16-year-old male who had bilateral CABG because of localized stenosis, RCA, and LAD. But the degree of RCA, degree of stenosis in RCA was moderate. 18 years day after operation, occlusion of right ITA was occluded. This shows a 16-year-old male who had bilateral CABG because of localized ITA graft occluded. 7 months after the operation, percutaneous balloon angioplasty was performed for the anastomotic stenosis of graft. 1 year after the operation, the native LAD was occluded. However, left ITA graft was patent. Years after the operation, a symptomatic occlusion, RCA, was occurred. Furthermore, an occlusion of LCA was also found. However, he was asymptomatic. Balloon angioplasty 2 to 3 months after the operation was effective for anastomotic stenosis. This slide shows a 19-year-old male patient with myocardial ischemia of the anteroceptor in myocardial perfusion imaging. Coronary angiogram shows an occlusion of the LAD. He underwent bilateral CABG, and myocardial ischemia improved. In a patient with multiple giant aneurysms, complete left CLBB was detected at 49-year-old. However, he was asymptomatic. His left ventricular ejection fraction by 2D had decreased. Serial coronary angiogram are shown. Coronary angiogram at 51-year-old showed an occlusion of the RCA. He underwent a bilateral CABG. After the CABG, cardiomegaly and left ventricular ejection fraction improved. CLBB and myocardial ischemia were also improved. This graph shows the relationship between the patency of graft and degree of stenosis. Degree of stenosis of the native artery. For severe coronary stenosis of more than 90%, the grafts were patent. In this indication, minimum coronary diameter was less than 1.0 millimeter. This is very important. It's simple. Usually, the coronary flow reserve is decreased for an 85% stenosis, 85% to 90% stenosis. Coronary flow reserve in each group measured by transthoracic echocardiography is shown. CFR was decreased in the localized stenosis group. Evaluation of myocardial ischemia, both anatomy and functional were evaluated. This 8-year-old patient had a localized stenosis of the RCA and an occlusion of the LAD. He underwent a bilateral CABG in the post-operative angiogram. The diameter of the bilateral grafts reflects the degree of the native flow. To maintain the patency of grafts, these 3 points are very important. Stenosis rate of the native artery diameter of stenosis diameter, existence of ischemia, balloon angioplasty at 2 to 3 months after operation. In the strategy for ACS caused by KD related to CAL, CABG is selected in patients with multiple vessel disease. Second talk is long-term result. This patient with bilateral giant aneurysm had intracoronary thrombolysis for acute myocardial infarction due to occlusion of the LAD in 8 years old. Further, he underwent bilateral CABG because of localized stenosis in 18 years old. Their procedures were successful. The coronary angiogram shows the long-term patency of graft of more than 40 years. The 30-year patency of internal thoracic graft was 83% in our institution. The patency of composite ITA graft was good and same as patency of single ITA graft. In the result of our institution, 40-year survival rate after CABG was 94%, and overall cardiac event-free survival rate was 61%. The no myocardial ischemia after CABG was found in 76% of patients. The 20-year cardiac event-free survival rate with patency of at least one graft was significantly higher than that in the group with graft occlusion. Incidence of STT change in treadmill test after CABG is shown. There is a significant difference between two groups. Incidence of perfusion defect in myocardial perfusion imaging after CABG is shown. There is a significant difference between two groups. Incidence of VT and NSVT after CABG is shown. There is a significant difference between two groups. This shows the number of CABG for Kawasaki disease patients from the 1970 in Japan. About 30 patients in each had undergone CABG. The number of CABG from the national clinical data from 2008 to 2019 is shown. The number of patients about 30 to 40. In this report, the median age at operation was 39 years old. In the previous survey of 2002, the median age was 11 years old. 50 years after the initial report of KD have passed, and the age of patients who have undergone CABG is older compared to the previous survey. This graph shows the relationship between the age at operation and number of coronary risk factors. The number of risk factors increased with aging. The number of each risk factor is shown. Hypertension and dyslipidemia were found in about 30% of patients. The number of patients with an emergency CABG was 37 patients, 10%, and cardiogenic shock was 10 patients. Acute myocardial infarction within 21 days was found in 8% of patients. For the preoperative left ventricular ejection fraction and preserved LVEF, moderate function and poor function were found in 55%, 39%, and 6%, respectively. The number of target vessels and each graft are shown. The mean number of grafts was 2.3. The medications after CABG were shown, and warfarin and statin were administered about 40% of patients. The condition at discharge after CABG is shown. Although 3 patients, 1% died, the result of CABG were favorable. The 10-year cardiac event-free survival rate was 75%, and 10 years repeat coronary revascularization-free, the 10-year survival rate was 93%. The 10-year overall cardiac event-free rate was 67%. 10-year cardiac event-free survival rate was 75%, and 10-year repeat coronary revascularization-free rate was 76%. For the survival rate, there was no significant difference between younger group and the older group at the age of operation. Further, there were no significant difference between the off-pump group and the on-pump group. The 5 5-year survival rate, depending on the preoperative LVEF, is shown. The 5-year survival rate in the poor group was 72%. It was significantly lower than that in the preserved LVEF group. Thank you for attention.
Thank you, Dr. Sudha. Your talk is now open for comments. So ever since we started doing CTCA, and which arteries are involved?
Predominantly they are left ventricular. We have 5 ventricular blocks, so we are probably 4 now, and critical stenosis and all in left ventricle. And probably you see man's data also, other than other arteries, but LED was definitely involved in all this.
So I think these 4 patients need to be proactively worked up.
Yes, at least my cardiovascular.
Why do we use statins in your settings?
Statins.
In other case, if cholesterol, LDL cholesterol increase, I choose. But children, I don't use.
You don't use till 18 years of age. Till 18 years of age, you don't use statins.
Yeah.
And if cholesterol is increasing yearly, then you start statins.
If the cholesterol is increasing, LDL is increasing.
100 to, in Japan, 100 to 30.
But if it is increasing, will you use statins if it goes up?
Yeah.
In children?
Yeah, no, in children I don't use. Yeah, but I don't use.
Do we need to profile regularly for giant resistance?
Giant
So are we doing lipid profile regularly for patients with giant resistance?
Each 3 months.
Each 3 months you are doing lipid?
For patient being for
children or adults?
Yeah.
For children?
Yeah.
Okay. Thank you, Dr. Sudha.
I would like to request Dr. Ramesh to chair the next session.
Good afternoon. So, my Dr. Manjri Agarwal is a consultant at Division of Pediatric Rheumatology at Bangaram Hospital, and she is into equal traveling fellowship holder, and ma'am will speak on the comparison of ECO versus CTC and coronary artery assessment of Kawasaki disease. So we are learning from last 3 days that what ECO can do and what CTC can do. So now, ma'am will try to give a comparative assessment of that. What are the literature which is available on that?
Thank you so much, and thank you, Dr. Rakesh, for the intro, and thank you for inviting me to this session. So, unfortunately, I could not attend the last 3 sessions, but the links to the talks really helped me. And I tried to see that what all was discussed. So yesterday I had to delete many of my slides because everything had already been discussed. So I thought I don't want to bore you guys. Otherwise you would start probably throwing tomatoes at me and tell me that everything has been discussed. So just get out of here. So what I did was I kind of summarized everything. So it's a very short
comprehensive talk, probably the shortest that you have heard in the last 3.5 days. So what I wanted to say first thing was that this topic is wrong. There is no comparison between echo and a CTCA. It's like you know how to walk, that's your echocardiography, and you know how to drive a car, that's a CTCA. You can't replace walking with a car. A car has its own value and walking has its own value. You can never replace echo by a CTCA. You can augment an echo by a CTCA. You cannot say that, oh, I have done a CTCA, now I will not do an echo. Would you do that? You have attended 3.5 days. Would any of you do that? No. So you would probably just see, why do we need CTCA? Just the fact that we needed some imaging modality beyond echo tells you that the echo might have got some limitations. So I've just tried to compile what are those. So it's a balance. There is no comparison. I'm here in between, and both are equal modalities. Both are good. There is no debate. Now, the role of echocardiography, we all know, it is done for an initial assessment. You have all heard the talks that you will not wait for the echo to be abnormal to make a diagnosis of Kawasaki disease. I hope that is very well, the point is very well taken, that you will not wait for that point that the echo is abnormal to make a diagnosis, and pediatricians make a lot of this mistake. We are all rheumatology people here, we don't do this, but pediatricians do that. They will say, but the echo is normal, so why are you giving IVIG? Oh, that's the point of giving IVIG. So that is something which they totally miss. So this is something which all of us should impress upon our pediatric colleagues, that you should not wait for the echo to become abnormal. Coronary artery evaluation can be very well done by echocardiography with limitations, yes. But for early detection of coronary artery dilatation or aneurysms, you will have to use echo as your first step. Assessment of cardiac function, other than the coronaries also, there is so much more. The myocardium, the valves, who's looking at all of that? The pericardial effusion, all of that you would be looking by an echo, and all the other pathologies need to be excluded. It is absolutely non-invasive, can be repeated as many times. I can do it daily, I can do it alternate day, I can do it twice a week. There is no risk of radiation, and you can calculate the coronary artery Z-scores. And yes, I heard the debate yesterday where there was a lot of problem with the coronary artery Z-score, and nobody knew how to use the infantometer, and nobody was measuring the height and the length properly. But yes, in spite of all of that, you would use the Z-scores, or you would use the coronary artery dimensions, and you know you would be accommodating the changes in the weight and height. And now, why do we need another imaging modality? Because this imaging modality must be having some limitations. What are they? First thing, it is hugely observer dependent. That is a huge disadvantage with echo. Now you ask me to stand and do a echo in front of the, so it will be like, I don't know, probably, I'd rather not say. So the observer would need to know what is the site of measurement, the proximal, you have to, do you measure from the ostium, do you measure a little away, how little away, in a heart who's beating at 120, 130, 140, a child who's crying, who's cranky, how do you measure, how do you identify, how do you do? So it's hugely observer dependent. So my first year fellow is doing, my second year fellow is doing, my cardiologist is doing, my new cardiologist is doing, my trained cardiologist is doing. It's a lot of a difference. So then the site of the measurement, then inside edge to edge needs to be seen. Have I gone a bit up? Have I gone a bit low? And that can change the dimension hugely, and that can change the Z-scores. As we saw yesterday, Dr. Narendra told us that even if you measure, it's a little different, the Z-score changes. So there's a huge variability. It is machine dependent. Even in our center, if a child is in the PICU, we have a machine over there, and we have a machine in the cardiac department. So they would say that, oh, we have measured, we have given you the dimensions, we are giving you the Z-score, but just, these are arbitrary, our machine is better. This machine is not better. So the probe frequency, the machine, it all matters. So it's one limitation. The probe is part of the machine. Sedation may be required. Sometimes we do with only the trichlorphos, that is the pedicloral, but sometimes you may require some ketamine or some midazolam in very, very irritable children and in crying children who are less than 3 years of age. In older children on follow-up, there is a poor acoustic window due to the thick anterior chest wall, and you may have a poor acoustic window, and the length and the height needs to be measured accurately, as you very well heard yesterday. There was no specific Z-score for Indian children. We need to have these Z-scores which are designed for our ethnicity, the age, race, gender matched specific Z-scores. With all of this, the distal coronaries are poorly seen. It is very well emphasized, and there are elegant studies by Dr. Rakesh here that where they have shown in a lot of children that the distal coronaries have aneurysms when they have been missed by doing the echos. It is difficult to view the left circumflex artery. Again, another paper from PGI which shows the same, and stenotic lesions cannot be delineated well, and vessel wall cannot be evaluated by the echo. So with all of these limitations, we need something else. I am not covering the MR angio today, but I am just covering the CTCA. So sensitivity of the echo to detect stenotic lesions is only 80% or even less, and it is more than 94% to 97% with the CTCA. And there are many papers to say that. Now, what are the advantages of a CT coronary angio? It overcomes almost all the limitations of a 2D echo. It is relatively non-invasive. When I say relatively, there is a cannula involved. The cannula needs to be a good 20 gauge to 22 gauge so that you can give that much of the dye, and then you need to do this. You get almost similar views as a catheter angiography, and catheter angiography is the gold standard, we all know, to delineate either a thrombosis or a stenosis, and even to give you the calcification in old lesions. The distal segment involvement is highlighted, as is the involvement of the left circumflex artery. So it is not dependent on the observer. You do the sequences and we will see what are the problems. Now the limitations. Now, radiation is the biggest concern that all of us have, and till I heard Sir's talk many years ago at the Chennai APLAR meeting, I used to think that, CT coronary angio should be reserved for children who grow up, and once they are adults, then we should be doing. And after that talk, my eyes were open, and then we started realizing that no, we should be doing it much earlier. And now the AHA 2017 and the 2024 also recommends all of that. But it is preferable to use a dual source multi-slice CT scanner, preferably something more than 64 slices, or 128 or a 320. Prospective ECG gating is better, and as another paper from Dr. Singhal and Dr. Rakesh Pilania here also suggested, in a retrospective gating was used and a prospective gating was used, and the radiation dose is much less with a prospective gating. And all of that was discussed yesterday, and I'm sure you all grasped that during the RR interval there's no radiation, so the overall radiation exposure is reduced to much less. But are these machines available everywhere? Is a cardiologist or a trained radiologist available everywhere? We can't divide Dr. Manful and put him in all centers. I wish we had a Dr. Manful Singhal for all the centers. And there is a risk in sedation, in injecting the dye, in giving the metoprolol and doing the inducing that bradycardia. And then again, this was also discussed yesterday. So a radiologist is available all the time for all the scans. Is it always possible? Suppose the radiologist is on leave, and so what will you do during that time? Will you not do the CTCAs? Who will do the CTCAs? Suppose you miss, suppose you are not able to optimize. So there is a knowledge gap over here which is immense, and this knowledge gap is tremendous, and this needs to be somehow fulfilled. So so there will be 3 teams required, probably a cardiologist, probably a pediatric sedation team, and probably a trained radiologist. It is not possible in all the setups all the time to have this. According to me, this is one of the biggest limitations. The radiation exposure is definitely a concern. So I understand that one CTCA is equivalent to about 10 chest x-rays. So what is a safe number of x-ray exposure in a growing child? So suppose I have a 1-year-old child and I do a CTCA at a baseline, then I'm doing a CTCA every year or every 3 years or every 5 years. So in the lifetime of this child, how many CTCAs can this child take? How many can we do safely? Are we justified in doing this, or are we justified in withholding it because of radiation exposure? I'm sorry, I do not have the answers to these questions. And I'm just comparing the 2 modalities. I'm neither in for this nor in for that. And again, nobody discussed cost yesterday. Why? Because you're all from institutes which are supported and funded by the state. Think about poor us. Think about our patients who are self-paying. How many times am I doing, the cost of a CTCA at my unit, in my hospital, it's in excess of 15,000. And that does not include the sedation cost. That does not include if a pediatric sedation team is involved, then please add another 5,000-6,000 to it. So this 20,000, every how many months, how many years, for how long, do we have the answer? No insurance is paying for that, mind you. The insurance might have paid for the IVIG, but the insurance is not going to be paying for the CTCA because they do not pay for evaluation. They just pay for treatment. And what treatment am I showing by doing this CTCA? This has hugely limited our doing CTCAs, and in fact, majority of the patients at Gangaram Hospital who have undergone a CTCA have been sent to us by Chandigarh, and they've got their CTCAs done over here. Because of this huge issue with the cost, and second with the radiation exposure, because our radiologists were very trigger happy. They said, yeah, send us patients, but we were like, hey, you don't have the low dose protocol, you don't know this, we can't risk our children over to you like that. And this was this amazing, elegant study with an emerging role of CT coronary angio in evaluation of children with Kawasaki disease. This really helped me broaden my horizons and to learn, and that's why I've placed this screenshot. All of you who have not read this study, I'm sure all of you might have, but jisne bhi nahi padhi, please go back and read this. So now this again, now as Sir was pointing out yesterday, and as that paper also gave that algorithm which yesterday was shown 2-3 times. So now think about this. When should we be doing a CTCA? The AHA recommendations are something different. But should you be doing it at baseline? Should you be doing it after IVIG? Should you be doing it in all children? Or should you be doing it only in children who have a proximal dilatation or an aneurysm to detect the later one? I tried to find the answers. I have no answers for this. All I could understand was that if you really want to say, if you want to be a purist and you want to say that I do not want to miss a single distal or a single left circumflex, then all children who have been diagnosed with Kawasaki disease should undergo an echo and a CTCA simultaneously. And that would you be able to do that? Do we have that much of infrastructure anywhere in the country? I don't think so. So then that means we are missing so many children. What about those children who did not show any proximal lesion on the echo, and I am just thinking that, oh, everything is normal. I have given IVIG, I am following up with the echo is normal, and I tell this family to stop the aspirin after 3 months or after 6 months. So am I justified in doing that? Have I missed a left circumflex? Have I missed a distal coronary artery lesion? Can this child go and die tomorrow just like that while playing? I don't know. And the AHA 2024 just talks about this. Just talks about this. So they say if your, where did it go? Yeah. So they say if your Z score is less than 2, they say don't do any advanced coronary imaging. So that means they are not saying that you are missing out a left circumflex or you are missing out distal aneurysms if your Z scores are less than 2 of the visualized coronary arteries. Then In the Z-scores 2 to 2.5 also they are not saying this. Now, in the Z-scores 2.5 to less than 5, now they are saying in small aneurysms, they are saying you may consider coronary CT angio at 1 year at baseline. What about this 1 year time? What do you keep doing in this 1 year? So do you keep continuing to use the antiplatelets for 1 year and do a CTCA? Once your CTCA is negative, then you stop it. What do you do? It's not clear. These guidelines really need to be read and reread, read the fine print, then read between the lines, and then see what are you doing at your unit, and then modify them according to whatever you want. Then again, if your aneurysm has regressed, again you are doing it at 1 year at baseline and may consider if there is an inducible ischemia. So again it is a may consider. So you are doing an inducible ischemia. So how would you do that in a 2-year-old? How would you do that in a 3-year-old? You've got an infant at 6 months. Now at 1 year you are doing the CTCA. So this is a 1.5-year-old. When are you going to induce ischemia and when are you going to do what? So no answers for that. Again 2 to 5, Z-score of 5 and less than 10. Again 1 year and may consider every 2 to 5 years. May consider every 3 to 5 years. It is so arbitrary. Is there any science behind it? Why 2 to 5? Why 3 to 5? What will happen in that 3 year? What will happen in that 5 years? No answers for that. So there is a huge lacuna when we are talking about CTCAs. It is not as simple as it seems. It is not simple as it sounds. We definitely need it. And now this is one unanswered question which I have left for my next speaker friend, and he is going to talk about this, and I was so happy to see this as the next talk. I said, chalo, ek kaam khatam hua. So I don't have to talk about that at all. That Z-scores measured by the 2D echo, can they be actually extrapolated? Is it the same thing? First you are saying that you cannot measure it properly on the echo. Now you are saying you extrapolate the same thing to the CTCA. So Dr. Satish is going to answer these questions for you. And in summary, I would say and finish by saying that there is no comparison required. Each modality has its own use. If you don't have anything, use your judgment. If you have echo, use it. If your cardiologist doesn't know how to measure the coronary arteries, then I would rather intensify the treatment rather than take a chance. And I don't know, CTCA I feel is underutilized, and I totally agree that wherever we have a CT machine, we should try to use the low dose protocol. We should try to use the prospective ECG gating. We should try to get the CTCAs done as much as possible. These are our inhibitions. Once we will lose them, we will start using it much more and more. Thank you.
Thank you, ma'am, for your talk, and you have posed several questions, and which is essential because we are still evolving in this, and we don't have set answers in this, because guidelines are also a well-crafted written documents. So they are that how can we circumvent the things, and that's what they have done, because in lack of evidence or lack of the major studies, the guidelines would be like this only because of expert opinion. So I will go with the questions and comment after Dr. Satish's talk. So next speaker is Dr. Satish Kumar Loganathan. He is an alumnus to our institute, and he is currently a consultant at CMC Vellore, and his special interests are primary immune deficiency and pediatric neurology. So he will be talking on a very interesting part which already Dr. Manjari has also highlighted, and Dr. Satish was also asking me that why you have given me such a tough task. I don't have much to do. But then I told that, yeah, I know that you can do that. That's why I have requested him. So he will try to answer that. Can we apply echo-based Z-scores on CTCA diameter? Because we day in and day out when we are doing echo and then CTCA, so there will be some diameter. So is it possible to compare these things? Over to Satish.
Thank you, sir. Thank you, Rakesh, sir, like inviting me. I know you are angry with me, that's why you gave this topic. Because 3-4 days I was searching in the PubMed, like only one article I can able to get from the Boston Children's Hospital. So in the world, nobody has thought about like comparing applying the echo based Z scores and the CTCA diameters. So while preparing this talk, that first slide, what first slide will give, I was discussing with Dr. Murugan also, like what to compare with the echocardiography and with the CTCA. So the echocardiography is like kind of the golf. You try to put the ball in the hole, and you will be like doing successively, try many times to achieve your target. And when you are try to achieve the target, like obviously you will be missing the distal part, left circumflex, stenotic, and aneurysm, the large aneurysms in the very remote areas. But this is like the Yusuf Dikek in the Paris Olympic. He came without any gear. He just came and shot and got the target. The CTCA, mostly we are trying to get the targets by doing the stenotic lesions, and your all aneurysms in the left circumflex, distal, everything is very clear. So the echocardiography, we measure the coronary artery luminal diameters from the inner edge to the inner edge in all the segments. And in the CTCA, how to define aneurysm? The aneurysm was defined as a coronary segment with the internal diameter of more than 1.5 times of the adjacent segment. At the same time, the dilatation is less than 1.5 times, and the stenosis says the presence of luminal narrowing in the coronary arteries. So the Z scores already past 2 days, we have a heated debate, and so many people contributed like which one to use, which one not to use. And for the justification for the echo Z scores, we have the studies. For CTCA, we don't have any normative data for coronary diameters for the pediatric population. So this is the application of echo Z scores to the CTCA measurements. The proximal part, everybody is comfortable. The pediatricians, rheumatologists, when we are SR, the proximal part is no problem. But the most of the time, the distal parts, like still there is a huge problem, and if you don't address it, like we can face the problems. So this is the one study from the Boston Children's Hospital. This was a retrospective study from 2016 to 2020. The inclusion criteria of history of all patients with Kawasaki disease and history of Kawasaki disease with the maximal coronary artery Z scores more than the 3, and they temporarily paired the echocardiogram and the CCT. So the 18 patients with the 21 paired echocardiogram they did with the CCT, and the timing is patient within 2 weeks of the KD onset, they get it on the same day for the inclusion in the study. For 2 to 12 weeks, they did within 7 days, and for 12 weeks to 1 year, they try to get within 30 days. So this is the statistical graph, Bland-Altman graph. This is when you want to compare two variables in one single graph. So this graph is measured. This is the Bland-Altman graph for LMCA. You see the bias is minus 0.03, and the limits of agreement is within the agreement that says there is no bias when they applied the Z scores for the coronary assessment for the echo and the CTCA. There is a very good agreement and there was not much bias. At the same time, for the proximal, the bias is very low, and the RCA, proximal RCA is also very low. Distal RCA, they are very comfortable, but the problem is like the distal LAD and the circumflex measurements, the wider line of agreement, and there is a bias is like almost there with the distal LAD and the circumflex measurements. So this one particular graph says when you measure the Z score, what are the changes you can compare with the echocardiogram and the CCT. So when the Z scores are between 5 to 10, there is no problem. But when the Z scores going beyond 5, 10, 15, 20, 25, whenever you measure from the echocardiogram, you overestimate compared to the CCT. So the dashed lines is for the proximal right coronary artery, and the solid lines for the proximal left anterior descending artery. So this paper says like the Z scores whenever is very high, there is a huge aneurysm is there, the echo actually overestimates the Z score compared to the coronary artery angiograph. So when they analyzed the inter-observer and intra-observer, they said like there is very, very less inter and intra-observer, and the agreement was very good with all the arteries. Only with the circumflex artery, they have a problem with the agreement. So in the conclusion of this particular paper, there is a strong agreement in the absolute coronary measurements between CCT and echocardiogram for proximal coronary artery segments, and there is a wider variation in the circumflex and the distal segments. And the echocardiograph tended to be larger than the CCT, particularly when the coronary artery aneurysms are very, very large. And the application of echocardiogram derived Z-score formulas for CCT measurements led to the lower risk stratification for the 24%, because in echo you measure them very high. When you do the CCTA, the lower risk stratification and the management changes in the 24% of this particular cohort. So when I was discussing with Dr. Manful sir, like what we are going to do with this, because when you want to compare with the echo and the CTCA, you need to have the bias should not be there between the in observers, like when one observer is doing, the another observer is doing, there should not be any bias. So sir was telling there is a technology, there is a automated measurements, edge detection for 2D echo and the CTCA. This can avoid the bias in the near future. Both the echo Z scores and the CTCA scores will be like comparable, and it may be like very, very precise. And the further studies may be like, I think the PGA trying to they are planning a cohort on this particular issue. And the take-home message is the good correlation with the proximal segments, and there is a wider variation is there in the distal segments. And the large aneurysm, they should be like interpreted with caution. Thank you.
Thank you, sir. So what we can see is that there is a very less data on this aspect, but whatever like one study has from Boston group has suggested that possibly in proximal segments we can correlate the diameters, but CTCA has helped in better stratification, or rather they have decreased the severity in when we perform the CTCA. So that both talks are often for comments or questions.
So I had a doubt, like in 1996 there was a paper from Catos on the long-term consequences of coronary aneurysms. So the data was like was spanning for around 18 years. So it was published in 1996 circulation. So he followed the patients who had aneurysms with invasive angiogram. So less than third month or the first angio, and subsequently a few years he used to repeat the angio. It was for around 500 patients, but he has not probably I didn't find any distal aneurysms in that invasive angiogram. But we could able to find at least 10% of the patients who had aneurysms in the proximal sites with distal aneurysms. So that was one surprise that I had. But patients who did not have any proximal aneurysms, probably there was no study till now who had undergone a CT angio. Isn't it, sir?
In fact, I think Dr. Rakesh, you would be a better person to answer this, because I had this doubt after reading this paper for the Z-score measurements, that are we over-diagnosing the distal segment involvement with the CTCA, because we are comparing it with the coronary which is tapering, so we are then saying it is 1.5 times, so are we over-diagnosing it, or did others miss it?
So what I can understand your question is that sensitivity and specificity of CTCA for distal CAs. So the definition for coronary artery abnormalities are secular or fusiform aneurysm, or if there are more than 1.5 times of the adjacent segment, which is not the proximal segment, it is comparison to the adjacent segment. So these are the anatomical variations, not that they are just taken the diameters only. And these were the two fusiform and secular aneurysms, and which were there. So and we are not comparing to the diameter proximal proximal coronary artery to the distal coronary artery, because that will be like it will be tapering normally only, but it is in comparison to the adjacent segment. So those are two CAs only. So that paper was from 594 patients in, so that was with Leroy Satato et al. So I don't know, I have not specifically looked into that whether they are seen the distal segment aneurysms, but they are still, because we have in CT coronary angiography, one more group which is working on CT coronary angiography is DAY4 group from the Netherlands, and they have also precisely shown that distal coronary artery aneurysms are seen. And if I remember correctly, in that paper published in the European Journal of Radiology, they have identified almost 4 patients out of 40 with isolated distal segment aneurysm, so which is reproducible also. So there are 2 distinct studies which I remember. One is from our center and one from DAY4 study. So both studies have suggested that distal coronary artery abnormalities can happen in absence of proximal coronary artery abnormalities, and CTCA outperforms. Within the DAY4 studies, they have given a graphical comparison also between ECHO and CTCA, and they have shown clearly that ECHO underestimate the coronary artery burden disease in Kawasaki disease, and more so in distal segment aneurysms. Dave.
First, on the lighter note, sir has compared CTC with a Turkish sugar who's coming without any kit and stays between bullseye. But at our place, we are having a lot of preparations and we have protocol in place. So I take offense on that.
Yeah.
Firstly. And
Yusuf Dikak, no. So he tried almost 3-4 Olympics. He's not come with the first time. So he won the silver. In the past, he attempted many times. The only thing is he don't have any gear. He just came and just put his hand in the pocket and just shoot it and cut it.
we have couple of gear. Secondly, sir, actually I agree with what you have told about it. We have also analyzed our data from CT angios, which is in a process of publication, from acute phase where CT angios were done. In that we have compared the immediate pre-CT echo to CTCA, and as you told in a few cases we have seen that echo has overestimated the sizes and CT angio has eventually come normal. So that even here also.
So while reading this paper, like the one interesting fact I have seen for this particular cohort, they gave nitroglycerin to reduce the heart. Sometimes when you give nitroglycerin, that reduces the flow and your size also becomes low. So that's why like your automated age that can give some amount of bias, like to reduce the bias. So that was like an interesting fact. I am not sure like the most of the metoprolol when we are using, that may not like underestimate the flow and the sizes.
Can't even comment on that. So, but you were talking about the automated softwares. One paper which we, I think has been discussed yesterday, DAY4 also, that how can you use this software, AI-based software for characterization of coronary artery abnormalities, and this, the literature on this has been already established actually. Any other? Abarna has published on left circumflex coronary artery abnormalities in Kawasaki disease, and she will be able to tell that what CTCA will do in comparison to echocardiography on LCX coronary. Abarna, please.
It's not just for publication, it's occasional situation. So yeah, like first, like CTCA is better in seeing LCX abnormality. There are like 4 cases of LCX that abnormality that have only LCX abnormality, those the other major arteries that was not picked up in echo. So even the patient had an initial proximal segment dilation, the follow-up it was normalized, but it was picked up in CTCA. So there are few benefits of CTCA to be in patients, those who are abnormal, not I'm not talking about normal.
Manjari has highlighted one more important point, is that regarding the cost of the procedure of the CTCA in private sectors, and this is a very important because again, if I correctly remember that doing a CTCA in a government setup is still a very easy task, because the cost of the several costs would be curtailed in that aspect, but yeah, it's a difficult thing, and possibly that is also a very important component, because again there is a sedation requirement that will also increase the cost in a private setting. So that is a very also a very important consideration. So this is a procedure which has to be conducted where the established protocols are available for the CT coordination, and radiation exposure is also a very important component, because yesterday only we have discussed that radiation exposure can be further minimized if you use the 4th generation CT scanners. That is, so in those it can be further minimized. Yeah.
So this is the issues related to the money fact. What I felt was that if they have an aneurysm with the thrombus, doubtful thrombus in the echo, there is a definite need for a CT angio in the acute aneurysm. The question will come when you don't do the CT angio in the initial 1 or 2 months, where the time for therapy has gone, and then the question will be like, even if you find, which may not be like a critical stenosis or a calcification takes some time, then we start asking the question that is it wiser to do it maybe 5 years later to reduce the cost, and we may not act on the initial CTA that we may do maybe 3 months later like that. So these are all some questions related to the money factor.
Yeah. Precisely because as you highlighted and Dr. Manjari has also highlighted that indication of CTCA, that comes to the indication of CTCA. What are the indication of CTCA during the acute phase? So still we don't know when to do CTCA, and as highlighted sir also yesterday that the most difficult questions to answer from the reviewers whenever we try to publish our data, that what is the indication of CTCA. So which is again a question that how what are the specific indications? Can we tell that 1, 2, 3, 4 indications? So in acute phase we know about the follow-up CTCA and chronic phase CTCA, that we can there are some guidance, but during the acute phase still it is an issue. But again, if there are any complications which can be addressed at that time, that is an important aspect. So if you will miss the thrombus, then that could be a very serious consequences, and in that way, and if you are CTCA reassures that yeah, everything is fine and there are aneurysms, but you can continue the treatment whatever you are continuing, so that is also another part. Yeah, ma'am, you want to say anything?
Yeah, so I totally agree with Dr. Murugan on that. So what we have done for this aspect is that we have we've got very few children luckily with who had giant aneurysms with thrombus, and we took SIR's help for all of those patients, and we sent all of them here. So what we have tried to do is to kind of utilize the CTCA, because ultimately it's the patient who should benefit by any technology anywhere. So we have sent the patients over here, and then we have also told them to keep following up over here, so that okay fine, they may be living in Delhi or nearby, but coming here once in a year or once in 2 years, once in 3 years is not a bad deal at all. And for children where they had giant aneurysms and where we were giving them the low molecular weight heparin, even if they did not have the thrombus on the echo, we send them here, so that you are doing the CTCA, you are telling us that no, there is no thrombus, and once that regresses, then we are happy to stop the low molecular weight heparin. And in fact, there is one patient I received in whom we have sent here 3 times that no, we will not stop till you go and get another CT angiogram, and then once you are given some green signal that yes, now you can stop, only then have to stop the low molecular weight heparin. But that is something that we have done for a select few children, but that does not address the bigger picture of doing it for all, missing the left circumflex, missing the distal aneurysms. There's no way out of it. Probably we need to do some kind of study with our ethics committee, and then the hospital can help fund some of it. Yeah.
Thank you. So if there are any other questions, there are none, we can break for a tea session. And post break we have oral presentations.
I was asking, there is none SR left who would like to exchange in place of you because you won't be available tomorrow. For example, I don't know Soumyadeep sir or Dr. Jamal. I'm just asking and being sure.
GIAN coronary aneurysm with thrombus in the same patient. So coming on to the GIAN coronary aneurysm, so it's a worldwide prevalence is around 0.07 to 0.20%, and in the study was first conducted in Japan, it showed that prevalence around 0.16%. The main risk factors which were identified in this study was the male 6 recurrent Kawasaki disease, delayed diagnosis, that is more than 8 days after KD onset, detection of coronary artery dilatation and aneurysm at the initial baseline cardiography which they have done, and resistance to IVIG treatment. In another study which was done in China, it showed they have followed up total 94 patients of KD with GIAN coronary aneurysms, and out of this 94, 54 patients had thrombus on follow-up, and mainly 41 out of these 54 patients had thrombus in acute phase, that is within first 16 days of the disease onset. And in this study also they have mentioned male 6 and the absolute diameter of aneurysm more than 8 mm, and that environment as a risk factor for thrombus formation. Then coming on to the case details, so he must have 8-year-old male, resident of Punjab, and came with complaints of fever for 1.5 months and redness of eyes for last 1.5 months, and was being followed up in multiple local hospitals for the persistent fever. On retrospective study, he also had redness and cracking of lips, and history of right-sided small-sized neck swelling. On examination, he had connectable injection and right-sided unitus vital lymphadenopathy and red lips. So seismic examination was normal, and the diagnosis of incomplete Kawasaki disease was kept. And inflammatory markers which were sent showed neutrophilic lymphocytosis and neutrophilic leukocytosis along with thrombocytosis and elevated ESR and CRP. Baseline echocardiographic findings showed moderate side aneurysm in left main coronary and GIAN coronary aneurysm in right coronary artery and left anterior descending artery. So CT angiography was also done during the acute phase, which showed pan-coronary aneurysms and dilatations along with a thrombus which was partial in the RCA occluding the lumen of the RCA. And these were the dimensions which were noticed, which were quite similar to the echo findings at the baseline. So during the admission, the child was managed with IVIG along with infliximab, steroids, and cyclosporine as a primary intensification. And for the GIAN coronary aneurysm, the patient was started on aspirin, enoxaparin, and atorvastatin. On follow-up, the steroids and cyclosporine were slowly tapered over 6 weeks. However, aspirin and atorvastatin was continued, and the LMWH was converted to warfarin with a target of INR between 1.5 to 2. And the follow-up echo findings show regression of coronary artery aneurysms in LMCA to the normalization, and RCA also, the aneurysm had regressed from the GIAN to moderate size, whereas LAD has persistent GIAN coronary aneurysms. So in follow-up in Jan 2025, he also underwent MR coronary angiography, which showed large size aneurysms in the LAD, and I also underwent perfusion MRI, which showed normal perfusion, but he had a small subendocardial infarction in the right inferior wall. So follow-up plan is to repeat a CT coronary angiography after 2 years of diagnosis, and to continue aspirin, warfarin, and atorvastatin as of now. And we have concluded from this cases that CTC is essential for detailed coronary artery abnormalities assessment with its complications such as thrombosis during the acute phase, which can be missed in the 2D echocardiography, and the role of MR coronary angiography for identifying infarcts and myocardial functional assessment. I would like to thank my faculty members, residents, and PhD students and staff of Pediatric Immunology Unit, and Dr. Manful Singer for providing us with the images for this GIAN conference. Thank you.
So how frequently did you do the echo in this child?
So ma'am, during acute phase we have done at day 1, then after the intensification therapy Then we have done it 6 weeks, then 3 monthly, ma'am. We are doing.
And you are given the IVIG, the infliximab and the steroids all together? Like
IVIG, cyclosporin, and steroids all together we are given, ma'am.
This type did not receive
Infliximab also given, ma'am.
And you stopped the cyclosporin
And
steroids?
Steroids were tapered off over 3 weeks and cyclosporin over 6 weeks, ma'am.
Message you want to give us?
So, sir, for acute, the importance of acute CTCA in these cases, such as he had giant coronary aneurysms along with the partial thrombus, and we have seen in the previous study which was done in China that 60% of the patients with giant coronary aneurysm have risk of thrombus formation in the acute phase. So to identify those patients and to the role of statins and prolonged anticoagulation therapy in these patients, requirement of and also to look for any evidence, and if we know that the patient is having thrombus, so further we can plan for MR coronary angiography to look for functional assessment as well in these patients, sir.
Is the incidence of thrombus-free giant aneurysm?
Sorry, sir?
Incidence of thrombus-free giant aneurysm.
So, sir, in the Japanese study, they have observed out of 144 patients, only around 10% to 12% have developed giant coronary aneurysm, but they have not mentioned about the exact incidence or prevalence of the free giant coronary aneurysm free from the thrombus.
The next speaker is Dr. Soumyadeep.
So my topic of discussion is a case of giant coronary aneurysm in a case of Kawasaki disease who did not respond despite adequate anti-inflammatory therapy. The child presented at the age of 1 year of age, who is a resident of the state of Bihar. The history dates back to March 2022, in which he developed a high-grade fever for a duration of 19 days, for which he received multiple antibiotics. He had a reddish discoloration of tongue, maculopapular rashes, irritability, as well as the reddish discoloration of eyes. However, no evidence of arthritis, cough or coryza was present. He also had a colitis-like symptom, loose stool for a period of 5 days and 8 to 10 times per day. However, no history of dysentery or vomiting was present. Now, at this time, he was treated with multiple IV and oral antibiotic but showed no response. The patient was diagnosed as a case of Kawasaki disease in Gangaram Hospital in Delhi. Now, at presentation, the child was anthropometrically normal but was febrile. After diagnosis, they did a echocardiography which showed a giant aneurysm in LAD as well as a presence of clot in LAD. The RCA and LMCA also showed a moderate aneurysm. They started IVIG at 2 gram per kg along with prednisolone, infliximab and cyclosporin. Aspirin as well as enoxaparin were also given. Now, however, despite the anti-inflammatory therapy, the LAD and RCA showed a progressive aneurysm and the size of the clots also started increasing. For this reason, he was referred to our institute. Despite the increasing in the size of the LAD or the RCA, the inflammatory markers were normal. The ESR was raised due to the IVIG therapy. However, the CRP at that time was 0.2 and the evidence of thrombocytosis was there, but other inflammatory markers were normal. Now, after coming to our institute, we did a CTCA which showed a 3 discontinuous aneurysm involving the RCA with partial thrombosis of the distal RCA. A fusiform aneurysm was present in LMCA. A thrombosed giant aneurysm in the proximal LAD was present along with collaterals. The LV apex showed a pseudoaneurysm which may be due to the thrombosed LAD. These are the images of the multiple aneurysms involving the RCA and the LAD. Now these are the images of the clot which is present in the LAD as well as some collaterals that are present. These are the arrows are showing the collaterals that are present because of the thrombosed LAD. Now the RCA showed 3 fusiform dilation which are shown in this image. The LV due to the infarction had resulted in a LV aneurysm in the CTCA. Now this is not the first time, however multiple cases like this are reported. This is a case in which an infant was diagnosed as a case of Kawasaki disease. After anti-inflammatory therapy still had a progressive aneurysm. Here it is a review of literature that is published in Frontiers of Pediatrics, also showed that in the infancy, although the fever and the inflammatory parameters show a convalescence, the echocardiography is needed to monitor for the cardiac changes. So despite adequate inflammatory therapy, the coronary aneurysm can progress, and coronary aneurysm can progress even if the inflammatory markers are normal. Thank you.
So how did the CT coronary angio contribute to this case?
Ma'am, the echocardiography revealed the increasing sizes of the coronary artery. However, the rupture of the LV apex, which resulted in a fusiform dilation of the LV apex, was revealed only by the CT coronary angiography.
So what management change was done?
Ma'am, after that we have started the beta blockers. We have started beta blockers, propranolol and carvedilol. Along with that, we have restricted the activities of the child. No contact sports have been allotted to the child, and the father and mother have been counseled. No stressful exercise is to be avoided for the child.
Have you done any follow-up on this?
Yes, ma'am. Yes, ma'am. Ma'am, the child has been planned for a CTCA after 1 year, and the stress test and the perfusion studies have been planned, ma'am.
What is new in your case?
Sir, as we follow up a patient of Kawasaki disease, we look for the inflammatory markers and the echocardiography. This case emphasizes the point that the cardiac involvement can progress even after the normalization of the inflammatory markers. Thank you, sir.
Next speaker is Dr. Radhika.
Good evening everyone. I am Radhika and I'll be presenting a case which I encountered during my MD. He was an 8-year-old boy hailing from Rajpura, Punjab, a fully immunized, developmentally normal child who has not had any illnesses pre-morbidly to this presentation. He presented with complaints of fever, which was a high grade fever spiking up to 102 degree Fahrenheit, lasting for up to 8 days. It was continuous in nature and not responding much to oral antipyretic agents. On day 2 of the fever, the mother noted that there was a swelling on the right side of his neck. By day 3 of this fever, he started to develop vomiting and abdominal pain, and there was an episode of passing pale colored stool. However, the color of urine was not noted by the parents. By day 4 of the high-grade fever, he developed redness of both his eyes. However, no discharge was noted. By day 8 of illness, he presented to the hospital near his home, and there he was noted to have strawberry tongue, a maculopapular rash all over the body, and bilateral pedal edema. The management for this illness, so from the day 1 to day 4 of the high-grade fever, he just received home-based oral antipyretic agents. By day 4 of illness, he had visited his local hospital, and there, in view of him passing pale-colored stools, which was preceded by vomiting and abdominal pain, he underwent a few basic blood work, which revealed conjugated hyperbilirubinemia and transaminitis. So, acute viral hepatitis was suspected. However, his fever kept persisting. By day 9 of illness, he was referred from this local hospital to another government hospital this time, which was in Chandigarh. Here he was diagnosed to have Kawasaki disease, and his blood work was done, which revealed leukocytosis to the tunes of 27,000, 22,000. His platelets, which were rising subsequently from day 9 to day 11 of fever, peaking at 8 lakhs. Total bilirubin maximum documented up to 4.6 with conjugated fraction of 3.8. His liver enzymes were elevated to the tunes of 89 and 71. Extreme elevation in the inflammatory markers with a CRP of 290 and an ESR of 70. Suspecting Kawasaki disease with the clinical signs and symptoms, he received IVIG on day 9 of the fever, and an echo was also done on day 9. This was the echo which in the outside hospital, which showed a dilatation of the left anterior descending, and he was however he was there for 2 days, but the fever still kept persisting, and he was given a dose of intravenous steroids and referred to PGI. Here he presented to us on day 12 of his high-grade fever. At this time, the child was kept as a case of IVIG-resistant Kawasaki disease with a coronary artery dilatation, and we did basic investigations. Again, he had leukocytosis with platelets now increased to the tune of 11 lakhs. His sodium was on the lower limit of normal, 133. His liver enzymes had increased to 92 and 112, but by the time he presented to us, his conjugated hyperbilirubinemia has started subsiding, and CRP was 152. In our hospital, he received 2 more doses of intravenous corticosteroids, and treatment intensification was also done with infliximab and cyclosporin. When we repeated an echo for this child, it revealed moderate-sized aneurysms in LAD, LCX, and RCA. So pan-coronary aneurysms had developed by the time of day 12 of the high-grade fever. And we also did an ultrasound of the abdomen, which showed that his gallbladder was partially distended. And since he had developed moderate-sized aneurysms, we initiated him on aspirin, atorvastatin, and low molecular weight heparin. We also did a CTCA in the acute phase for this child, which revealed very clearly that there was, this is the aorta showing very beautifully that there is enlargement of pan-coronary enlargement is noted. In the left coronary artery, there was an aneurysm at the bifurcation, which was 5.4 into 6.7 mm in size. Left anterior descending artery also showed fusiform dilatations, 2 of them. Then in his left circumflex artery, here we can see that it was fusiformly dilated with a maximum diameter of 5.7 mm. Right coronary artery had multiple discontinuous aneurysms, of which the maximum was 7.8 mm in caliber for a length of almost 5 mm. However, there was no evidence of thrombosis. After this CTCA and treatment intensification, the child was discharged. He had become afebrile. On subsequent follow-up, day 20 of illness, desquamation was noted in the periungual regions, and his echos that we performed on follow-up were as follows: at 2 weeks, 6 weeks, 2 months, 6 months, and 9 months, which showed that there is some regression in the size of the coronary aneurysms. And regarding his therapy, his steroids were gradually tapered and stopped, and low molecular weight heparin was switched to oral warfarin. A quick brush through the literature search on this. So as we know, Kawasaki disease is the most common acute vasculitis in childhood. It is heralded by a prodromal phase. It can have complete, incomplete, or atypical presentations. Usually GI involvement is noted sometimes, but it is not as a part of the criteria. And upon doing a literature search, I found that febrile cholestatic jaundice is one of the main forms of the GI presentation. And usually we'll note the gallbladder ultrasound abnormalities. So owing to this atypical presentation, as in our case, the diagnosis usually gets a bit delayed. And this increases the likelihood of developing coronary artery complications subsequently, and increases the morbidity as well as the mortality for patients. So we should consider the intensification of therapy in cases of atypical KD, and the giant aneurysms usually managed conservatively, and of course the long-term follow-up in such cases is mandatory. Thank you.
anything specific for the hepatic manifestation?
Ma'am, actually the child presented to us on day 12 of his high-grade fever. By that time, the conjugated hyperbilirubinemia had already started becoming normal. Like we have one record of his LFTs which was normal, total bilirubin and conjugated. And subsequently, as he became afebrile, the transaminitis also improved. So we didn't target any specific therapy towards that.
Did you do any viral markers for this patient?
Yes, ma'am. In order to keep the slides concise, I have not mentioned, but in the outside hospital, he did, since they suspected acute viral hepatitis at the outset, they sent the viral markers which were found to be negative. And since the fever was still persisting, that was the reason they referred the child to the government hospital.
Is there anything new in your case?
The novelty is just that we don't commonly see this kind of a GI onset illness, and usually we will confuse it for being more of an acute viral hepatitis since that is more common. And if we do an ultrasound abdomen, in some cases we do see hydrops of the gallbladder, which in this case was also possibly the cause for that conjugated hyperbilirubinemia. And since we will not suspect KD at the outset, the diagnosis will get delayed and hence more morbidity for our patients.
Next speaker is Dr. Yamini.
Very good afternoon. I'll be presenting 3 cases of Kawasaki disease with coronary artery aneurysms and their subsequent follow-up with CTCA. So, as you know, the Kawasaki disease is a medium vessel vasculitis of unknown etiology, and combination of IVIG and immunosuppressive therapy have dramatically reduced the incidence of coronary artery aneurysm. 0.13 to 0.82% of patients still suffer from CAs with varying sizes. So CAs sometimes dilate rapidly in the, as we know that CAs dilate rapidly in the acute phase of KD, but the progressive dilatation and new aneurysm formation in the remote phase is a rare phenomena. So I'll be discussing this aspect. So with this background, I'll start with my first case. Master R, his 13-year-old boy, was diagnosed as a case of complete Kawasaki disease at the age of 5 years. Sorry for the font, I think it has changed now. So the investigations at the presentation, he had thrombocytosis, he has raised inflammatory parameters, and the 2D echocardiogram at the baseline was suggestive of a small aneurysm of LCA. So this was the CTCA which was done at 5 years of age in the year 2017, which was suggestive of dilatation of LCA with 3.7 mm size, and there was a distal RCA medium-sized aneurysm plus 9.09 Z-score, and LCX was also dilated. So when we did a follow-up CTCA at 10 years of age in the year 2022, we found that the distal RCA measured, the size has increased from 5.2 to 7.2 mm, and the aneurysm which was seen in LC and LCX have regressed. So this was the comparison. In year 2017, the RCA aneurysm measured 5.8 mm, whereas in 2022 in follow-up CTCA, the RCA aneurysm has increased to 7.2 mm. So this is case 2, a Master S, 15-year-old boy, was diagnosed as a case of complete Kawasaki disease at the age of 4 years. His investigation at the baseline was suggestive of increased inflammatory parameters, and the 2D echocardiogram which was done at the diagnosis was suggestive of a giant coronary aneurysm in LMCA and a medium-sized aneurysm in LADA and a dilatation in RCA. So the CTCA which was done at 4 years of age in the year 2015 showed aneurysm dilatation in distal LCA and proximal LAD with a width of 4.5 mm and length of 7.8 mm. So, but when we repeated his CTCA at the age of 11 years, in year 2022, we were surprised to see that we had a new dilatation of RCA, And the aneurysm, which was initially in lad, also increased in width and length. So case 3, his master age, 10 years old boy, was diagnosed with a case of incomplete Kawasaki disease at the age of 6 years, had raised inflammatory parameters, and his baseline 2D echocardiogram was suggestive of giant coronary aneurysm in LAD and a giant coronary aneurysm in LCX and a medium aneurysm in RCA. The CT coronary angiography in the year 2021 at the age of 6 years was suggestive of 3 discontinuous fusiform aneurysm in the proximal and mid segment of RCA, and there was a proximal fusiform aneurysm in LAD, and again a giant fusiform aneurysm in LCX. So when we repeated the CT coronary angiogram in year 2024 at the age of 11 years, the fusiform aneurysm in the RCA have regressed. Initially there were 3 fusiform aneurysm, but now we had only 2, and also the diameter has decreased. The LCX giant aneurysm has regressed to only small dilatation, but the proximal LAD continues to be same and it was increased in size. So this is a comparison of my 3 cases. In case 1, the initial CTCA showed right coronary artery aneurysm measuring 5.8 mm. In 2022, the right coronary aneurysm increased to size 7.2 mm. For the case 2, the fusiform aneurysm in LAD, which was 4.5 into 7.8 mm, increased to 5 into 10 mm, and a new distal RCA dilatation was noticed. And for the case 3, the proximal LAD fusiform aneurysm increased in size. So I would like to quote this paper, which was published in 2005 by Professor Suda et al. And it was a huge series of patients which was published. In it, 562 patients were studied, in which 17 new dilated or expanded lesions were found in 15 patients. That is 3% of the patients. And the time of detection of new aneurysm after KD ranged from 1.9 to 19.2 years, with a median of 11.4 years. 13 new aneurysms occurred in vessels in which previous aneurysms had regressed, and all new aneurysms were associated with the localized stenosis. But in our cases, we didn't find any localized stenosis. 2 expanding aneurysms were seen, one from 4.4 to 19.5 over 17 years, and the other increased from 10 to 15 mm in 1 year. So this is the second case which was published in Journal of Cardiology in 2021, where a 33-year-old pregnant woman with a history of giant coronary artery aneurysm secondary to KD had a progressive dilatation of her RC aneurysm from 7.5 to 25 mm at 30 years of age. So what peculiar was that in this, they studied the pathology of the coronary artery aneurysm. Here we can see that the internal elastic lamina was disintegrated and a lot of smooth muscle cells were seen and a neovascularization was seen. And this was different from the typical aneurysm which we see in KD. So the different features in this case from those seen in typical coronary arteries were, there was no evidence of luminal calcification and fibrotic change of the internal elastic lamina, thickening of the media with degeneration characterized by an irregular smooth muscle rich layer in conjugation with partially fragmented IEL, and acidic mucopolysaccharide deposition around the new vessels. So I would like to conclude with that. The enlargement of a coronary aneurysm after the acute phase in KD is an extremely rare phenomena, and these patients should be followed more closely. Mechanism underlying the development of new aneurysm in the late phase are unclear. Possible causes can be growth of the coronary artery with somatic growth, abnormalities of the coronary artery wall, hemodynamic factors, and role of CTCA in detailed visualization of the coronary artery. Thank you. The somatic growth.
What about the Z-scores in these cases? You mentioned absolute dimensions. So in a 5-year follow-up, these children must have grown in weight and height. So what about, of course, the aneurysm particularly, you may not be able to give a Z-score in an absolute dimension. What about the others?
In the first case, which I've shown, the RCA aneurysm, the absolute dimension increased from 5.5 to 7.5. However, the Z-score didn't increase much. But So this can be a possible cause for that, the increasing somatic growth of the coronary arteries. Because the data on this is very scarce, and only I could find few case reports only. The data was very scarce for these kind of presentations.
Do you have any hypothetical suggestion or true suggestions how they can be prevented?
How they can be prevented? I think, sir, what I would suggest would be a timely intensification and more intensification of the treatment, because in one of our cases, the child didn't receive primary intensification. So maybe intensification of the treatment may have decreased the incidence.
Intensification of treatment, the acute phase, chronic phase, and which phase?
In acute phase, sir.
And how can we prevent the chronic phase?
Sir, it's a hypothetical, sir. We don't know the cause behind the...
Thank you.
Thank you, sir.
For the last session of the day, I would like to request Professor Surjit Singh to chair the session.
Coronary artery sequelae, clinical decision making in choosing the surgical modality.
Mr. Chairman, ladies and gentlemen, I greatly appreciate the opportunity to speak at this session. PCI in young children present two major challenges. First, the femoral artery and region itself are small and limit the size of useful vessel, and second, the coexistence of giant aneurysm with local stenosis may limit the achievable improvement. In the emergency revascularization therapy, we have three possible procedures. The revascularization for ACS has three aims: to reduce the size of eventual infarct. Ischemia is associated with reduced myocardial mortality and improved long-term prognosis. Effective PCI is shown. First, I present data of PTCRA. In our institution, the following factors favor selection of PTCRA for treatment: evidence of ischemia and single vessel disease rather than multi-vessel disease, limitation of bar size confining the procedure to bigger children. However, if revascularization with coronary artery bypass grafting rather than the target vessel is contemplated, combined therapy would be useful in patients with multi-vessel disease. Another restriction is that of possible thrombotic occlusion after rotational atherectomy. Consequently, localized stenosis with giant aneurysm is considered to be unsuitable for PTCRA in our institution. Our institution data is shown. 14 patients underwent PTCRA with mean age of 13 years. In this slide, the location of the target branches are shown. The left pie graph shows the initial birth size, and right side is the maximum birth size. Immediately, the result of PTCRA was successful in all patients. The medication after PTCRA is shown. The 15-year survival rate was 93%. Rate is related to acute myocardial infarction 3 months after PTCRA occurred in one patient. This patient had 2 vessel occlusion and had undergone PTCRA on the last vessel. As a result of this experience, coronary artery bypass grafting should be selected for future cases. Cardiac events free rate after PTCRA is shown. 5 cardiac events occurred in 4 patients. All occurred within 1 year PTCRA. All 4 patients underwent PTCRA when less than 10 years old, had asymptomatic occlusion. All occlusions occurred within 1 year after the procedure. In the patient more than or equal to 10 years, 15-year patency rate was 60%. I present images of 4 patients. This patient had underwent PTCRA at the age of 12 years. Coronary angiogram after 5 years showed good patency. She has had no symptom for 20 years. In the next slide, although the immediate result was good, asymptomatic occlusion was found 3 months after the original procedure. Although this patient had PTCRA for restenosis 1 year after PTCRA, good patency persisted for 15 years after PTCRA. The last patient had acute myocardial infarction and restenosis. He had PTCRA for localized stenosis with calcification. The first PTCRA was successful. Images of optimal coherence tomography before and after the procedure are shown. However, he had chest pain due to acute myocardial infarction 6 days after PTCRA. To our regret, he had not taken aspirin after procedure because of a mistake by the medical staff. In the emergency PCI, aspiration of thrombus and balloon angioplasty were done. The use of algatroban effectively prevented thrombus formation. The emergency PCI was successful. Coronary angiogram after 3 months did not show any restenosis. However, he had chest pain again 9 months after PTCRA during exercise. Coronary angiogram at 11 months after PTCRA showed severe restenosis. PTCRA was performed. The image in site of restenosis by OCT is shown. The lumen of restenosis site was occupied by newly proliferated intima. The result of PTCRA were poor in small children because of the use of small bar. The use of larger bar with close follow-up and rotational atherectomy can procedure good patency in older children and adults. Second talk is optimal revascularization strategy for acute coronary syndrome in the adult patient with KD. I will talk about 3 results. The first study is our hospital data, and second is PCI report, JROD DPC. The third is CABG report from NCD. Patients with acute coronary syndrome are taken to emergency hospitals, with most of them often as young adults having ACS due to atherosclerosis, without considering coronary artery lesion due to Kawasaki disease. Management of giant aneurysms and severe coronary artery calcification, which are characteristic of CALs caused by KD, should be considered carefully. The pathogenesis of the coronary artery disease differs between atherosclerosis and KD. Some adverse effects, first-generation stent implantation, were reported in this population, such as new appearance of aneurysm, fracture, and malapposition of the stent in the late period. In the first, we reviewed the clinical course of 11 adult patients who had undertaken coronary revascularization for ACS caused by coronary artery lesion due to KD from 1993 to 2020, based on medical record and selective coronary angiogram, intravascular ultrasound, and optical coherence tomography imaging. There are 9 male patients and 2 female patients. The age at ACS ranged from 19 to 47 years, with a median of 31 years. The years of their birth ranged from 1969 to 1989, with a median of 1973. 8 patients had history of KD, and 5 patients had dropped out. Median interval from acute KD to ACS was 27 years, and median follow-up after ACS was 13 years. 7 patients had some coronary risk factors, and 4 had no risk factor. The option for coronary artery revascularization was divided into 3 groups. One was coronary artery bypass grafting CABG group, and second was stentless PCI group. And third is primary stent implantation group. CABG was performed in patients with unstable angina and multiple lesions. On the other hand, in 9 patients with acute myocardial infarction, PCI was performed. There were 4 stentless PCI and 5 stent implantation. The graph showed the year and age at ACS in the 11 patients. The age at ACS was increased with time, After 2010, primary stent implantation was performed. This is a case with cabbage. A 13-year-old man visited our emergency clinic because of chest pain. The right coronary artery was occluded and local stenosis in the left anterior descending artery was found at the age of 19 years. He had dropped out at 20 years old. His electrocardiogram is shown. Negative T waves are found in 1 AVL and V3, V6. Localized stenosis with severe calcification had progressed. CABG to the RCA and LAD was performed. Two patients with unstable angina underwent multiple CABG with internal thoracic artery. The grafts have been patent for more than 15 years. They had no cardiac events after operation. The second case is stentless PCI. A 33-year-old female visited emergency clinic because of back and left shoulder pain. She had coronary risk factors, obesity, and smoking. An emergency CAG showed complete occlusion of the RCA due to massive thrombus. The distal RCA was injected through from left coronary artery. Repeated aspiration of the thrombus and percutaneous balloon angioplasty was successful. Simple aspiration or thrombotic therapy is not always successful because of the large volume thrombus in the giant aneurysm. In such cases, balloon angioplasty is often added. This table shows characteristic and outcome in patients with stentless PCI. For the target region, there were 2 RCA and 1 LAD and 1 left main trunk. There are 2 aspirations and 2 intracoronary thrombolysis. Balloon angioplasty was added in 2 patients. Warfarin and DOACs are added in all 4 patients. The third case is primary stent implantation. A 32-year-old man developed AMI due to complete occlusion with severe calcification of the LAD and underwent emergency stent implantation. Massive thrombus was aspirated. It was red blood cell thrombus. There was no atherosclerosis plaque. He had experienced scarlet fever as a child. 1 year after stent implantation, there is a very contrast staining. However, it was disappeared after 2 years. A 31-year-old man had localized stenosis with an aneurysm in the RCA. However, he dropped out from follow-up at another hospital. He developed sudden chest pain while walking. His emergency coronary angiogram showed 90% stenosis with an aneurysm segment 1. Severe coronary artery calcification was found in the culprit region on IVAS. After rotational atherectomy, A stent in segment 2 and second stent in segment 1 were implanted. There was no restenosis on coronary angiogram at 1 year after stent implantation. However, OCT showed a slight malposition in aneurysm. Five patients underwent primary stent implantation. There were 4 LAD and 1 RCA. There were 1 BMS and 4 second-generation drug-eluting stent. All procedures were successful. In the follow-up angiogram, peristent coronary staining was found in 2 patients and slightly malposition in 1 patient. This table shows medication and outcome in the 3 groups. Antiplatelets were administered in all patients, and warfarin was taken in more than 50% of patients in the PCI group. There were no cardiac events in any of the patients. However, 2 non-cardiac events occurred. In summary, there are 3 asymptomatic adult patients with coronary artery lesion caused by KD who remained undiagnosed. 10 patients, 91% had coronary aneurysm and a coronary artery calcification. 9 patients, 81% had giant aneurysm. 5 among 8 patients dropped out from the follow-up after KD. Coronary risk factors were found in 7 patients, 61%. There were no complications during the procedure. There were no cardiac events in the late period. For the next, Anzai reported the characteristic of the PCI for carrots caused by KD J-load from 2012-2019. They compared KD with non-KD. The prevalence of AMI KD was 0.1% of total patients. The age at AMI in KD was significantly younger. The prevalence of coronary risk factors in KD patients was half that of the non-KD. The prevalence of PCI in KD group was lower than that in non-KD. The prevalence of each PCI procedure, except for stent implantation, was significantly higher in the KD group. The ratio of stent implantation in KD was low. The percentage of mechanical support in KD group was significantly higher. That reflected a severe hemodynamic condition. Regarding the medication at discharge, the ratio of anticoagulation in the KD group was significantly higher. The ratio of clopidogrel, ACI, ARB, and statin in KD group was significantly lower. The ratio of in-hospital cardiopulmonary resuscitation was significantly higher in this population. The last result on emergency CABG, the numbers of CABG from the national clinical data. From 2008-2019 are shown. The number of patients with emergency CABG was 37 patients, 10%, and cardiogenic shock was 10%, 10 patient, 3%. Mechanical support during pre-operation was used about 10%. The number of patients with acute myocardial infarction within 21 days was 28 patients, 8%. The condition of discharge after CABG is shown. Although 3 patients died, the result of CABG were favorable. AMI-KD patient underwent non-PCI strategy such as CABG, ICT and IVCT, and required intensive therapy using IABP PCPS. When KD patients underwent PCI, stentless PCI using balloon angioplasty or rotablator was performed, more than in those with AMI complicated KD than in those with AMI non-KD. It is unknown that stent is useful for preventing reocclusion of carotid lesion. Second generation stent implantation with everolimus eluting stent is an acceptable method without adverse effect in the short time period. The long-term outcome after stent implantation in this population remains unknown. ACS caused by KD carriers in strategy is shown. CABG is selected in patients with multiple vessel disease. Thank you for attention.
Thank you, Dr. Suda. So with this, we come to the end of the day's session. If there are any questions to Dr. Suda? So I think one important message that all of us need to take is that we have several young patients with AMI in all cardiology units in our country. And a proportion of these patients are probably secondary to Kawasaki disease. And they remain undiagnosed. So they have not been diagnosed during childhood, and I think even after the procedure in the cardiology units, they probably would remain undiagnosed unless the cardiology team has some awareness about Kawasaki disease. I wish some of the cardiologists had come today. Any questions? Dr. Mansoor, what has been your experience of interacting with a cardiologist?
Once we see your CT angles, it doesn't look like atherosclerotic. It looks like more of AD. We have tried refracting them, but they are ugly useful. So, they will not give an adequate fit. There is no series defined. But those lesions were unobstructed. They were dilated, but I still have to see a patient having blood signs of Kawasaki disease. This stenosis present in myocardial infarction. I have not seen or discussed in any other cardiology reports like that. Though definitely they are.
My question is regarding the stent placement in stent-based PCI. What is the role? And what I have understood that stent-based PCI is still a controversial thing in Kawasaki disease. What is the
I don't know in detail. In adult cardiologist, it's usually our institution stent implantation, and in young age, outcome of stent implant after stent implantation remains unknown. But adult cardiologists anxiety re-occlusion after PCI, and they are likely to stent implantation. But my opinion, stentless PCI is favorable.
This is actually very pertinent question. You know, these are not my views. These are the views of Professor Kiran, who are a legal researcher. And when we met, I asked this question to him. This question, he was very, very categorical. If your child has stenotic lesion, which is causing myocardial ischemia, not presented with function, he should go with CAP. If patient having stenotic lesion presenting with myocardial function, then thrombolytic therapy provided with plus and minus, CAP. He was a view that the lesions that we get with Kawasaki disease, having tight stenosis, should not undergo any percutaneous therapies in the form of, the rotablators or the problem comes with all the cases that madam has are all adults. We have, probably they are all adults. The young children. So I asked this question, how this artery is going to behave in the child grows up. Say if you have done CAP at 9 years, 10 years, and he is the only man probably who has expertise of doing CAP in such children. He says in his experience that when the artery grows, that anastomosis gets unaffected. This was his view.
The patient that we lost, he was I think 13 years old.
13 years old, yes.
So, what would you have done?
Sir, first thing we would have done a myocardial perfusion study. And that patient has two tight stenosis, one in the proximal LAD and another in the mid LAD. Probably I don't think so. I've seen only one patient, and that was operated in somewhere else. He had a chest pain, and they did a CT angiogram, and they found an thrombosed artery, what was reported in the report. And I saw the films, it was in thrombosed aneurysm. And the bypass graft was done without isolating the thrombosed area. And we have discussed that in forum here. Sometimes definitely that artery is getting perfusion. The thrombus will definitely sometimes dislodge and cause inversion. So sir, until unless we know about things, I will never see. And we will, what we not sure on know, we do what we have been doing in routine.
I mean, this child that we are talking of, he had presented with incomplete KD 7 years ago. He was doing well on conservative therapy, but he was regular on therapy. But he decided to go for a morning run and he collapsed. So he must have had an infarct. He didn't come back home. So I think the first thing that we need to do is salvage the remaining 4 patients who have stenosis and see if some of them can be taken up by the cardiologists, oblique the cardiothoracic surgeons. So they should not meet the same fate as this child. Ripudam?
My question is evidence of PCI versus thrombolysis in patients with acute MI in KD. PCI versus thrombolysis.
Yeah. After PCI, thrombosis, in children, it should thrombolysis should be better, should be performed.
Any experience from any other center? CMC? Any?
follow-ups that you are aware of in cardiology there?
I have seen one patient recently who was followed up with cardiology for 5 years, who had a thrombus at initial diagnosis, managed with anticoagulants. We have done CT angio, which is now at present does not have any thrombus, and additional sites are regressed to, I think, moderate sizes.
You think that was KD?
No, he was managed as KD.
Okay, okay.
Known KD, but had thrombus initially.
Manjari? Your old follow-up patients, anyone you've had any issues with? They must have become adolescents and adults now.
None of the adults.
Thank you very